Now okay. Hello? We can't listen to him. We can't listen to him. No, we can't listen to him.
Doctor's mic is not working.
No, we can't listen to him. Okay, then come on. If he can't speak there, Bhagyalakshmi, you invite madam because something is wrong with the speaker. You invite madam to give a talk. Bhagyalakshmi, unmute.
I'll post my chat.
Start the program. Start.
So welcome to the first session of Gynaecologic Oncology, and the first opening batsman is no one else than Dr. Usha Sarai. I think she is the best person to do justice to the subject, and she'll be speaking to us about cervical cancer. Prevention is a priority. I think we all will agree to that, because everyone knows that IVF, laparoscopy, everything is a luxury. Everything is happy doing it. But women dying of cervical cancer is simply not acceptable. So I think madam has done tremendous work in this field, and she is the best person. So madam, we are eagerly waiting to hear from you. Kindly go ahead.
Can I share the slides? Can you share my screen? May I have my first? I'm ready to do that. Please give me the sharing of the screen, please.
Oh, yeah, sure. Yeah, it says provided to you, doctor. It's provided to you. You can share your slides.
Yeah. No. Let's say share. Yes. Am I audible? Can you hear me?
Yes, madam. Yes.
Good. Okay. So the topic given to me by the organizers is cervical cancer prevention a priority. Now the question is, what do you mean by priority? Is it the priority now, or since when has it been a priority, and has it ever ceased to be a priority? Well, let's pay attention to these factors. Priority, it has been from 1967, when WHO for the first time announced that it is a preventable disease and qualified it or classified it as a preventable disease. And at that time, we thought it was quite a progressive thing to say, when all we had was a pap smear, that too not all over the world, and colposcopy in some of the centers. Since then, a lot of progress has been made, and it has suddenly become more of a priority. And I think that is important to know. And that is when our motto changed to Elimination of Cancer Cervix, a FIGO declaration, which came in November 2018. So then I thought, for the benefit of all our members who have joined this program, let us see the path traveled so far and the way ahead, and how do we prioritize this program in the near future. And this picture, all of you have seen before, I'm sure, and I'm proud to show you again, because we had Dr. C.N. Purandare as president of FIGO and Nirja Batla as chairman of the Oncology Committee, when they gave this goal to everybody, and along with WHO and UNFPA, gave a call for commitment to collaborate on global effort to accelerate national action. And I think because 2 Indians were there, I think India is should be little more committed to working on this in the immediate future. Now, first, I would like to explain what is elimination and what is eradication. And in elimination, we continue all interventions to eliminate the disease in subsequent generations. It's not just now, it is Generations, the next generation will be the young girls and the generation after that. And when it is successful, then we will talk of the next phase. And the next phase will be eradication, when all interventions are stopped, no longer required. And that stage has reached for smallpox already, as you know. And then maybe no vaccinations are done because no cases are reported. So at the moment, let us remember to use the word elimination. Now, what have we done so far to get to this stage? You can't suddenly get to that stage, it has to have a little background. So all this time, WHO and WHO cancer control. Is there something Bhagyam wants to say? Or shall I continue? Yeah, it is called CCCC, in which we do vaccination, screening, diagnosis, and treatment, which also involves formation of guidelines. And Foxy ICOG has done that, and we are right on time to get all this organized. Then national health system must support. The government has to support us. And they have started, many states have started, many attempts have been made to take it to the primary health medical centers. District hospitals have been upgraded, but much more effort is needed on that count. A very strong disease management and palliation. And I do want to emphasize this to all our members, that is the Foxy ICOG members. Please don't forget the late cases. You will still see more late cases than you will see early cases. And you must give them palliative treatment, and you must have a very strong attitude towards correct management of whatever the stage that the patient comes to you. And this I'm saying because we are talking to Foxy ICOG members. The management is in their hands. National Cancer Registry has to monitor the impact, and they're doing very well. We have many cancer registries all over India, and from time to time they do report on the facts and figures, and we must have access to that data. That is little difficult, and we must know, are we going in the right direction? Now, this no organized government screening program, I'm saying because it's a state subject, health is a state subject, and each state is responsible for making their own screening program, but the data has to be compiled together in that cancer registry. And all this, I feel there is scope for improvement, and we must do something. And we are trying. For the last 40 years, we are trying to set up everything. So what WHO and FIGO have said, that the policy of control of cervical cancer continues. Please don't abandon any of these things that we have worked so hard to establish. It has to be strengthened. Whatever is the weakness, we must all get together and see how to overcome these difficult things. And we have to make it much more effective. And I want to emphasize that in India, awareness is still a problem. And without awareness, without the patient's cooperation, without patients coming forward to ask for these tests and cooperating with us, nothing will be achieved. So please remember, our question of awareness is still to be addressed by us, the doctors, which is very difficult. Now, let me give you some figures, and I really think figures are so difficult to remember. And when I ask students and postgraduates also to quote some figures, they are at a loss. So I'm making a table which is very simple to remember. You won't have any problem remembering this. This is from Globocan. I've analyzed 2008 and 2012, incidence per 100,000 and mortality for 100,000. In an unscreened population, it is said you will find an incidence of 28 cancer cervix cases to 100,000 women between the ages of 35 and 64. Now, in Australia, in 2008, it was 5.5, and in 2012, 6.7. 5 or 6 is the figure in UK and USA and Australia. Of course, in 2018, it has come down to 1 and 2, but remember, this is the figure in the developed world. And that's why they are ready for elimination, because the figures have come down to this basic minimum. And they had said that without vaccination, these figures cannot go below this. Now look at our country, we are also coming down. We are also doing better than what we were. It used to be 27 per 100,000 in 2008. Now it is 2012, it was 21.5. Now look at the other table of mortality, which is really much more important than the incidence. And you can see in Australia, UK, USA, they lose 1 or 2 patients out of 100,000 to this disease. That means even if they get cases, the cases come early enough for a proper cure and proper treatment. 1 or 2 per 100,000. Whereas in our country, it was 18 before, and now in 2012, it became 12.4. And I have got some current reality from Globocan 18 for you, especially for India. Mortality, which was above 1 lakh, 1,20,000 has come down to 95,000, and I expect it to come down again this year also. It will make a difference. Incidence has come to about 15 per lakh from 42 per lakh. I think these figures you will all remember very easily. It's not complicated. Then Bhutan, Sri Lanka, Thailand, Maldives have introduced the vaccine. So has Sikkim, and pilot projects have started in several of our neighboring countries. And this is this India Against Cancer big scheme, and this school children are given this training. But this is not about cervical cancer. It is more about tobacco-related cancers and other things. So I think the youth should be given some information and some idea about this, but it is not something we can talk about very easily to the young generation, because they have to be prepared for all these things. We don't want to frighten. Our motto is enlighten, but don't frighten. Now, in elimination, what are our goals? And this is something each gynecologist should know by heart. What is the ultimate goal given to you to bring about elimination? 90% of the girls have to be fully vaccinated with the HPV vaccine by the age of 15 years or whatever, around that age. 70% of the women are screened with a high precision test. Now, I don't know what we can call a high precision test, but a good, fair, accurate test. At least twice, once at the age of 35 and second at the age of 45. You can have any protocol you like every 3 years for so many years, and depending on what the facilities are available, depending on what the patient is able to come for, that is up to you to decide for your own patient population. And 90% of women identified with cervical disease must receive treatment, care, and a long-term follow-up. I'm going to come to this long-term follow-up, which to my mind is very important. Now, we can't do anything without a good HPV DNA test. With us, we need it for protection against cervical disease. Tests are expensive and available in metro cities. We are still awaiting the CARE HPV test, which is going to cost under $5, I believe. And many organizations are working on this, and they are going to give a preferential price for public sector. Let us hope that work on this is also going to increase substantially. Now, this is my own paper, which I have published in the Indian Journal of Obstetrics and Gynecology, JOGI, some years ago. Please remember, HPV is multicentric disease, and it can happen anywhere in the genital tract. The challenge, that is the challenge for diagnosis and treatment. A very large surface area of the epithelium is exposed to the virus. Now, which part of the epithelium is going to respond and how is a question. It is going to happen. It is going to be examined and treated by you. And there is an individual cell virus interaction. And we have all these problems to deal with when we are dealing with a patient. The individual cell is called the immunity or the host response. And that will depend on what the patient's immune status is. It will depend on her nutritional status. It will depend on her living conditions, her lifestyle, her knowledge about personal hygiene or facilities for personal hygiene, many imponderables. And the virus interaction will depend on which virus she's infected with. Is it 1 or is it 16 plus 18? Or does she have a cocktail of viruses? There are papers I have read which says whether a cocktail of viruses is sometimes helpful because they get antibodies from each of the viruses. So we have a lot of imponderables, when you deal with a patient, and how can we take everything into action? So my reason for mentioning to you is for this multicentric disease, if you want to diagnose from where all she has lesions of HPV, colposcope is the ideal method. Now, I don't want to tell you much about this. You're going to hear about it. All I want to tell you is for diagnosis, 5 and 10x is okay. 15x is required for if you want to study the vasculature, if you want to see the mosaic patterns and the punctations. And if you want to treat, you need quite high, 20x for treatment and target biopsies and things like that. And you have to use the green filter, and you have to study the entire genital tract, not just 10 minutes on the cervix and you're finished with colposcopy. It doesn't happen that way. Now, what comes before the precancerous lesions? I know we are concentrating on pre-invasive disease of the cervix, but let me tell you that when a woman has already started getting a dysplasia, that means her body immunity is low and she's already been affected by the disease, and it's a question of time what's going to happen to her. So way back in 1967, Coppelson and Reed realized this and said the behavior of squamous metaplasia, holds the key to understanding the cervical oncogenesis. And epithelium, which is in the reparative mode, is very susceptible to oncogenes like HPV. So we have to really, as a gynecologist, be aware of these things. I know not much can be done by us because metaplasia is a part of life and it occurs after every abortion, every delivery, every contraceptive use sometimes. So, but we have to be aware that that is the phase when oncogenesis may start. Now, there are many cofactors which come into play. Again, we have to be aware of these. A woman who has got a high parity, has had very poor obstetric care, tears and lacerations of the cervix, you can see. We don't have so much problem with prolonged use of OCs as they have in other countries, but we do have a problem with tobacco use and smoking. Smoking, not so much, but tobacco use is quite rampant. And of course, HIV is a significant factor. Other genital tract infections are important, and I will be coming to that in a little while. Then a low socio-economic score, that is very important, and a poor diet, a lack of folic acid, lack of vitamin A. You know vitamin A, what it does to the conjunctiva when there is keratosis because of vitamin A deficiency. There are epithelia, the nasal epithelium is so susceptible to these vitamins and vitamin C. So please remember, this is epithelium like any other, and folic acid is very important. In my early years in cytology training, we used to have a differential diagnosis between folic acid deficiency changes and early dysplasia. So the factors like alleviation of poverty, better housing, and empowering women are all in our domain. We have to realize without all these things, you're not going to be very successful in eliminating cervical cancer. Now I come to the role of infection in carcinogenesis, because that's a very important factor. Currently, we are very aware of it. that several microorganisms coexist and form the cervical microbiome. Cellular immunity is lowered by infection. Chronic and recurrent infection has a well-known association with genesis in all parts of the body, not just the cervix. And chemical substances from inflammation may be additional carcinogens. This is something new that they have found. Inflammatory exudate itself has chemical substances which may be additional carcinogens. And for all this, to keep the genital tract infection in control, our best friend is the Dodeline's bacilli, you know that, and they make the pH acidic and prevent the pathogens from growing. So if you don't see Dodeline's bacilli in the smear, we have to just report upon it. And it's very important to do in the Bethesda classification. There is a form for infections and presence or absence of Dodeline's bacilli, and that is because it is a significant factor in our management of the case. Now, this study from Latin America, it's not new, it's 2006, but it's very important, and it was one of the first which really gave us the importance of genital tract infections. It says vaginal infection promotes HPV infection in developing countries. Microabrasions are common in bacterial vaginosis. And Candida infection, they found, was common in low-grade SIL, and Trichomonas was more often seen in high-grade SIL, and HSV2 associated with other viral diseases. For a while, for some time, for a few years, there was a lot of work on HSV2 and HPV acting together, but they're all viral diseases and maybe they're associated in some way. Now, they've also stated that infection is a cofactor in CIN, and it's a factor that we can control and we can treat. So that is where our role comes in. It may also be a pitfall, and you may miss a CIN on pap smear. If you are doing the pap smears regularly, you'll find that sometimes you may miss. So you have to repeat the pap smear after treatment of infection if you want to make a correct diagnosis. And they have suggested this repeat after treatment for this reason. And in the repeat smears, the Dodeline's bacilli should be definitely there. So please remember all these factors, because you are the doctors who are going to treat our patients. And it is your thinking and your application of your knowledge which will prevent the patient from going into the pre-invasive lesion and invasive lesion. So I don't want to talk about this. You will be having others who will talk about it. And I'm just putting it up for you to know that we have 3 tests: visual inspection, pap smear. I don't call colposcopy a diagnostic test. And we have the HPV DNA testing as screening tests. And whatever is available, we'll be discussing that later. Now, I know we do a lot of camps, and everyone has been doing a lot of camps. The camps are not exactly satisfactory, but they're not reaching the patient. So we have to reach the rural population of ours, a large population. And we have other aims, not just to pick up a dysplasia. We have to create awareness, impart knowledge about cancer, collect data. Many things can be achieved by these camps. And I know that FOXY members are very involved in doing this, and let us continue with this activity, because it is doing more good than harm. Some people are a little worried, and these are some of the camp pictures that we have done, and we are very happy and satisfied with this. People like to talk about the condition, they like to ask questions, and they at least go away satisfied they've learned something. Now, vaccination in India, you're going to have a lecture right after this, so I don't want to discuss anything. But I just wanted to tell you that we started very well when Soumya Swaminathan was in ICMR. ICMR took the lead, was a driving force. And so many schoolgirls did start getting vaccinated in 2016, 17, 18. And now I hope it has picked up in other states also. So I come to the unfinished agenda, what I call that we have to provide appropriate management of pre-invasive lesions so that the sun can set on invasive cervical cancer. I've been saying it for 20, 30 years, and I know that this is still something we have to do. Now, this again is going to be covered again, so I don't want to say anything, but now the tools are there and the knowledge is there with you in the form of this booklet. So you can definitely go ahead and start. And the only thing I want to tell you is don't forget these special groups, because they are really special and the same rules don't apply to them. And please worry about the reaction of the patient to the diagnosis of sin, because most of them fear that they've already got a cancer. So I worked out a protocol of how to break this news to the patient and her family, and some other time I will tell you about it. But here I want to say something again, which is my own statement, which I believe in intensely, and which also is something I teach my students, that VIA, cytology, colposcopy, HPV testing are all individually fallible. You may not get the result that you want or get a final diagnosis based on one test. They're very, very valuable. And when you have to treat the whole patient and not just the reports, I feel the use of what we call ancillary tests and ancillary techniques are very, very useful if you have that academic bent of mind that I want to treat her correctly, I don't want to overtreat, I don't want to undertreat, and I want to give her the best chance to come out of this condition. So just remember that there is help for you if you have need. Now, this is the problem that I'm facing currently in a very big way, is the long-term follow-up. And I would like to refer to you to refer to this Melnikov's article. He's from British Columbia, and there are one or two other people who have worked on this. And their experience is that large number of recurrences occur in the first 6 years after treatment. Now, we have been saying maybe that 2 years at least follow-up you must have after treatment. I don't know what the other experts are going to say today, but according to this report, 6 years at least you must have very good follow-up and treatment. They have said CIN occurs 37 in 1,000. In a case of CIN treated, the incidence of cervical cancer is 37 per 100,000. Whereas in a normal cohort, it is only 6 per 100,000. So please remember that conservative treatment is what we are doing at present, and the need for follow-up is for 6 years. And also disturbing to know that cryotherapy associated with highest number of recurrences. So watch these patients very carefully. Risk is higher in women aged above 40 years. Again, something for you, a mental note when you're dealing with a patient. And they have said that we need more information, because information is crucial for developing the correct strategies and follow-up. And I do hope that our AOGIN and our other organizations will make some effort with the help of maybe ICMR to have these long-term follow-up studies from our own country, from some of our institutes which are doing very good work and who have the ability to study the cases for a longer period of time. This is another new thing which I have just picked up in the year 2020 journal, and it is the use of prophylactic HPV vaccine to prevent recurrence. I'm just giving this as a information which has just come. There were 5,744 citations and 5 studies comprising of 3,562 patients. Not a very big number, but it was their experience that incidence of histologically confirmed CIN2 plus had decreased in the vaccinated group compared to the unvaccinated group. So it had some protective action. And the number needed to prevent one recurrence was 27 patients should be given the prophylactic vaccine. I hope more information will come on this subject, and whether we should make it our practice, we have to yet decide. And prophylactic or adjuvant HPV vaccination reduces the risk of recurrent cervical intraepithelial neoplasia. Something for you to think about, something for you to look up in literature and perhaps maybe try out whenever you can. Now, there are 2-3 organizations which are working, and I just want to mention what they have suggested, what will help us. There are organizations called Together, Family Planning 2020, JAPIGO, and many other agencies met in 2019. And they suggested integration of cervical cancer and family planning services. They are going to be synergistic. And if you do good family planning, it will reduce cervical cancer. And they have the same patient population, and the personnel required is same, and the messages to be given will help both the programs. Now, whether this is feasible or not feasible, we have yet to plan out and decide. But this was done earlier, I know, because I started my career with ICMR as a research officer doing cytology, colposcopy in contraceptive users. So it is not a new concept, but it may be brought out again now. And global initiative against HPV and cervical cancer, which is adopted by AMWA, the American Medical Women's Association. And I belong to the Medical Women's International Association, and they have also suggested that we must work with other women's organizations to bring about the change in thinking that we need to have. And Indiana University has taken up this project in a big way, and we are waiting to see what their suggestions are and what it is to be done. And with this, I want to end my talk, and I just want to give you this quotation of Robert Kennedy. A very good mind he had, and he would have been made a very good president, but fate was willed it otherwise, and he was assassinated and could never take up this post. But he said, few will have the greatness to bend history, but each one of us can work to change a small position of the events. And in the total of all those acts will be the history of this generation. So we are seeing light at the end of the tunnel. Let's always be very positive, and let us always look forward to reaching the end of the tunnel, which we know we are going to do. And prevention, early detection, we have worked on. Public education, we still need to work on more. HPV testing is inadequate, and we need more facilities. And you will soon be hearing about HPV vaccines for the primary prevention. And all I want to tell you is there is an increasing role of gynecologists to do all this. And we cannot run away from our responsibilities when we say that we are here to serve the women of India and look after their health. Well, this is one aspect of their health that we are committed to looking after. Thank you very much. And I don't want to go into the talk of vaccines, which is for the next speaker. So with these few words, I hope I have covered the topic as per Bhagyam's instructions and given you where we stand and where we are going next. Thank you so much.
Yeah, thank you, madam, for that very, very enlightening, comprehensive, and wonderful talk. And I feel really privileged to work with you in Kama Hospital and on the international platform as a Vice President MWI, doing a lot of work, and I'm really privileged. Thank you, madam. I want to welcome Dr. Alpesh Gandhi. Dr. Alpesh Gandhi, our President Foxy, welcome. And I want to say you some inaugural speech, and I want to inform Dr. Alpesh Gandhi that this is the third course which we are having in this month of the certificate course, and it is one of the best course. Actually, there is a lot of huge response for this, and I want you to say a few words about this. Dr. Alpesh Gandhi.
Thank you very much, Madam Dr. Mandakini Meg, for inviting me and giving me this opportunity to share my views. First of all, I would like to congratulate you the chairperson ICOG, Secretary Dr. Parag Biniwale, Dr. Parul Potdawala, and Dr. Bhagyalakshmi, Oncology, Gynaecologic Committee Chairperson, Foxy, for this very, very useful, informative course. I am happy to see that this year ICOG is very active, proactive, and is doing lots of activity in this difficult time of COVID-19 pandemic. ICOG is doing excellent work under your able leadership. I am happy to see that our ICOG credit points are accepted like anything. It is in great demand. I am also happy to see that we have started some courses like Gynaecology course, 3 days Gynaecology course, ICOG certificate course, and I am also happy to know that you are also running webinars for the fellowship students. So overall, ICOG is doing excellent work.
Thank you, sir.
Particularly, I would like to say for the cervical cancer that probably I do not know whether it is mentioned previously or not, but WHO has declared that in 2018, 3,11,000 women died because of cervical cancer. And out of these, 85% of women died in a lower or middle income countries. And one more thing is India is the second number country having the highest number of caseload of cervical cancer. At the same time, India is probably number one country in the mortality wise, because in India, it is said that we have more than 1 lakh women every year, but they come to us when the stage is advanced. And so therefore mortality is very, very high. We all know that WHO has given a call for elimination of cervical cancer by 2030 by 30%, and WHO has given a call for vaccinating girls, screening of more than 70% of women between 35 to 45 years, and also for HPV vaccines, HPV testing. So as a Foxy, as a responsible organization, one of the largest federation of the world, and main policy makers, and we are taking care of women's healthcare in India. So it is our responsibility to see that our country also achieve the call given by FIGO and at the WHO. So it is also our aim to see that in our country also we can reduce the mortality because of this cervical cancer and other cancers related to women's. I will not take much time, but I am happy to mention that I am fully agree with Madam. Just in the last sentence, Madam has mentioned that there is an increasing role of gynecologist. And that is very, very true. It is our duty, and day to day we should do counseling from adolescent girls to menopausal and all the reproductive age group for this vaccination and screening, and try to eliminating the cervical cancer from our country. Thank you very much for giving me this opportunity, and I wish happy learning and very good day to all of you, and stay healthy, stay safe, stay connected. We are routinely connected by webinars, day-to-day webinars. Thank you very much for inviting me and giving me these few minutes. Thank you.
Dr. Alpesh Gandhi.
Sorry, I could not join in time because previous webinar was delayed. So sorry for that. Thank you very much.
So Dr. Alpesh Gandhi, thank you very much for your very motivational word. And we will be further motivated to do more work, and we will take full advantage of the lockdown and spread the knowledge as ICOG aims and objective. I'd like to say,
Madam, can I take 1 minute? Madam, can I take 1 minute?
Please, please, please.
I just want to convey thanks to all the societies and all the viewers. You all know that on International Women's Day, 8th March, we celebrated for the mega screening camps for cervical and breast cancer. And we have screened nearly 40,000 women in the police staff or in police and CRPF families. So it's a great response, and we have never thought of this this very good response in spite of this COVID-19 time, and more than 200 societies participated, and we conducted this camp completely free of charge. So I am thankful to all the participants who gave their services, and all the societies who participated in it. Thank you very much.
Thank you, Dr. Alpesh Gandhi. I'd like to say, Bhagya Lakshmi to say a few words as a course coordinator. And Parag would like to say something.
Yes, sir. Sir, welcome to our this webinar. I think there's a lot of webinars going on reproductive medicine and all that, but I think oncology is slowly gaining momentum. I'm so happy about that. At present we have 486 people who have joined in. And sir,
this is not webinar. This is certificate.
Sorry, it's a certificate course. I'm so sorry.
We don't use ICOG.
Yes, madam. I'm sorry. And sir, you'll be happy to know that Dr. Partha Basu from WHO is here with us today. So Dr. Partha is here. So we have a WHO representative. So I think he will take the message from us, and we can work together with WHO also.
Today, Alpesh,
thank you, sir.
We have best of the panel, which we can. Neerja Vatla from FIGO previous. Usha Saraya madam.
So we have all the stalwarts,
Yes.
So very nice. So I think we should continue with our program, scientific program.
Yeah, thank you, Dr. Alpesh. Just wanted to inform you that this is the second year Dr. Bhagya Lakshmi is conducting this kind of course. Last year in 4 societies, she did conduct postgraduate courses for 2 days. And this is a continuation of the similar activity. Thank you all very much for always being so supportive. And over to you, Bhagya Lakshmi, for continuation.
Thank you, sir. I think we can go ahead with our scientific program, sir, with your permission.
Join the screen join. Ask him to join my screen. Share the screen.
Okay, so our next speaker, I think Dr. Janmajay wants to introduce madam.
But ask him to share my screen, Raghu.
Yeah, it is shared. It's shared, Madhuri.
No, it is not actually.
This is Barsha's. So Dr. Janmajay wanted to introduce madam.
Okay. This is wrong. Okay. Please introduce or whatever. Share the screen. I can't share the screen. Now it's okay. Now it's all right. Yeah.
So Dr. Janmajay, is he here?
Now, hello.
Yes.
Dr. Mandakini Meg is the next speaker. She will talk on HPV vaccination. Dr. Mandakini is the chairperson ICOG Efficacy, is the international vice president MWIA, Central Asia chairperson MOGS, past vice president Efficacy from West Zone, executive committee member of IFAU-MB, past president IFAU-MB 2004 to 2005, dean of Indian College of Medical Ultrasound from 2010 to 2013, ex-chairman imaging committee Efficacy, dean of Indian Medical Ultrasound.
Bhagya Lakshmi,
so much.
Bhagya Lakshmi, I can't actually share my screen. It is his presentation. No, it is
okay, madam, please.
No, I can't share my screen.
No, madam.
No, you don't display. I am displaying because I want to control, na. I want to share the screen. Yeah, please. No, you don't have.
Okay, madam, please start.
Okay, 1 minute. One minute, please. How can I go about it? The first slide, Raghu?
Just double click the first slide, doctor. Double click the first slide.
No, it is not. It is quite below.
Click first slide and just double click.
1 minute.
Just use your arrow key, our arrow key.
Okay.
Forward up arrow key. Just use your up arrow key. It will take you to the first slide. Up
Okay.
arrow key. Yeah.
Doing it. No, it's not coming. Top. Okay. And now it's okay. Yeah. Okay. Yeah.
Just or take the mouse
Yes.
cursor on the first screen. Okay. Yeah.
I'm doing. It's okay. Yeah. Yes. So good evening, friends. After the madam's excellent talk, now the responsibility is
Hello?
of prevention of
Hello.
cancer. Can you hear me?
Yes, yes.
Yeah. Prevention of cervical cancer. I'm going to talk on the HPV vaccine. Now, as madam has already mentioned about the global burden of the cervical cancer, about 5 lakh women are diagnosed per year, 270,000 deaths per year, 1 million new cases, and 1 out of every woman die of cervical cancer at the world over. And India, every year 1,34,000 Indian women are diagnosed with cervical cancer. Dr. Alpesh Gandhi has already mentioned, Saraya madam has mentioned, but the figures are startling. And cervical cancer ranks #1 among the cancers of Indian women. So that is the burden on health services and a global burden. Now, if you look at the HPV infection is a necessary cause for the cervical cancer. And if you look at the causes attributed here, cervix, out of the total 492,800, 100% cause is a HPV infection. Now, HPV infections are very common and up to 80% of the women acquire HPV infection in their lifetime. The risk of the oncogenic HPV infection is very, very high after the first intercourse and continues throughout a woman's sexually active lifetime. So, after marriage or even before the sex they are having, they are immediately exposed to the HPV infections. Although new infections decreases with the age, risk of their persistence increase with the age. The cumulative risk of acquiring cervical HPV infection in women is almost 46%. We are all aware that HPV is the main causative organism of the cervical cancer, and around 15 strains have been found out of the HPV which have got a strong oncogenic potential. And you can see here, and 95% of the cervical cancer are caused by these strains of the HPV. Now, how does the vaccine act? Vaccine acts by the neutralizing antibodies. They play a very important role. You can see here neutralizing antibodies and a role in the vaccine-induced protection. Now, how many types of the vaccines are there? Initially, it is a bivalent vaccine. We are all aware of it. Quadrivalent vaccine, Gardasil. Gardasil is more advanced, and now the Gardasil 9 has also come. Now, Gardasil against it, it works against the HPV 6 strain, 11, 16, 18, and 14, and it is very, very good. And now even the Gardasil 9 has got a very, very effective antiviral effect. Indian vaccine under the development of Government of India considering the Gardasil at present to be given in the national program. Now, if they're looking at the safety and approval, WHO representative Dr. Partho is already here. As per the WHO Global Advisory Committee on the vaccine safety concluded that HPV vaccines had very good safety profiles. There are many studies, madam has also shown, and I'm also going to show few of the studies which shows that HPV vaccine outweighs the risk than the advantages. So it is very, very good as the safety measures. Food and Drug Administration approved the Cervarix on 15th October 2009. Now, value of vaccination today. Vaccination is one of the greatest public achievement in the world. We have seen many photographs, and we have eliminated in India, we have eliminated many diseases through vaccination. Oral polio and other such big diseases, smallpox has been eradicated. Similarly, we also plan to eradicate cervical cancer totally. With the exception of the clean drinking water, vaccines are most effective in intervention, reducing and preventing the return of infectious diseases. Similarly, 26 diseases are now vaccine preventable. So we are wanting that let's add cervical cancer also to this list. The HPV vaccination, very important point, that HPV vaccination is not included in the immunization program of India, but Indian Pediatric Association have included HPV vaccination in universal immunization program, but as a optional. But now, at the moment, it is not in the national program. So friends, what is the need? We have already talked about data. HPV vaccine is a major breakthrough in preventing medicine and protect against the cancer. Many strains of the HPV vaccines are treated. As per the Rio Declaration, I think Dr. Nirja Batla was there. WHO and elimination of the cervical cancer is the prime importance. And also, friends, I want to tell you that government of India has come out with the non-communicable diseases in which the cervical cancer prevention is given a lot of budget, and very, very important subject to deal with is very important in the non-communicable diseases. Now here again, it's a very great moment of pride for us that Nobel Prize winner discovery of HPV, a German virologist, Harald Zur Hussein, received the award for his discovery of HPV, the human papilloma virus. And you can see our Sarya madam, with him, giving him her book, which has been Atlas of the Cytology, finding the viral link in the early 1970s. He has received the prestigious Nobel Prize in 2008. So it is a great moment of proud for us also. Now, Madam has already shown that Somaya Swaminathan, who is WHO's newly deputy director, has been working very well in the ICMR, and her work is known in the tuberculosis HIV. Now, she has here some of the data. November 2016, Delhi and Punjab have started in the school girls. Some sporadic states have started giving the vaccination, but not all India. In Delhi also 1200 doses were given, Punjab and other states. And ICMR is a driving force for formulating the national policy, which may come within 2 or 3 years. Now, we have to look the long-term safety of the HPV vaccine. Kaiser et al. In the study from California has mentioned around 2 million doses have been given to the women. Only 12,000 had adverse reaction, and only there were majors were Guillain-Barré syndrome and chronic fatigue syndrome. Otherwise, there are all minor symptoms. So it is quite safe to give the HPV vaccine. Now, a very interesting study. Mean age of how many girls need to be vaccinated. Mean age of getting the cervical cancer is 38 years. Mean life expectancy is, I think here given 62 years. Lifetime risk is 2.8%. Cumulative mortality is 1.7%. And vaccine efficacy is 82%. If you calculate all these, then to prevent one case of cervical cancer, you have to give 44 girls needs to be vaccinated. And to prevent one cervical cancer death, 71 girls has to be vaccinated, which is a very, very important basis for giving the HPV vaccine. To save one life, here 3 girls need to be vaccinated. Very beautiful calculation. It has been shared by Dr. Usha Sarai, madam. Thank you, madam. Now, the recommended age of vaccination. The recommended age is 9 to 12 years. It can be included in the school program. Australia has already done it. Up to 26 years, you have to catch up age. Up to 46 years also, we can give in the catch up age. So it is a prophylactic vaccine and not a therapeutic vaccine. So again, the recommendation by the advisory committee of the immunization practices advises that HPV vaccination should be initiated in the female in the age of 11 or 12 years. It can be started as early as 9 years, but generally from 11 to 12 years. It is recommended that 13 to 26 years for it is saying males also, but here we are actually recommending only for the females. In addition, vaccination is recommended to have the sex with the men, and immunocompromised cases, we have to have separate vaccination schedule. Ideally, HPV vaccine should be administered before potential exposure to the HPV through sexual contact. Now, ideally, if you see the vaccine schedule, HPV vaccine should be started before the 15th birthday. Doses should be separated by the 6 years, and minimum interval is 5 calendar months. And if less third dose is given, at least 6 months after the first dose, it is recommended by the WHO in 2014. And also, 3 dose if is recommended for the series after the 15th birthday. The doses are 3, and for the people of certain immunocompromising condition, also 3 doses should be given. Compromising condition is cancer, HIV infections, or taking immunosuppressive drugs. So this is a schedule. Again, the catch-up vaccination I have already mentioned. This is around 56 countries has already adopted the national HPV vaccine program. Our country is yet to adopt. Then how effective is the this? As I mentioned, the Gardasil is the new entrant in the vaccine world. FDA approved. In addition to the quadrivalent, it also prevents from the strain of 6, 11, 16, 18, and it also includes 13, 3, 45, 52, and 58. These are the viral strains of the HPV. It has the potential to prevent 90% of all the cervical cancer. And 14,000 cases has been reported with the 97% of the effectiveness. It is the most updated vaccine. What about the already vaccinated women should be revaccinated? So here, and the same vaccine here, it is given the strains, and genital ward prevention 6 and 11. It also has got the effect of the genital wards. Now, the efficacy of the vaccine in national immunization program world over is vaccination is now a part of immunization system in more than 55 countries. Australia, they already started in 2007, and vaccination of the school girls has been started. Vaccine efficacy is 98% in the women who are HPV naive. Now, there is a Finland experience, Finland study. I'm just showing you the figures because time is less. Vaccination cases where only vaccination was given, prevention rate was 91%, where vaccination and screening both were done every 10 years, and it is 94%, and vaccination and screening every 5 years, it is 97%. So coverage of 97% is a very, very good response and very good prevention rates. So these are again few studies. I'm not going to go in the details, but Australia, United States, Denmark, madam has already shown this same slide. But the USA, the reduction in the strains of 6, 11, 16, 18 infection is about 89%. That is what I'm going to stress here. Now, what do we know about the safety? We already said. In India, I must mention here that India, the trial was started, but the young girl in a tribal district were vaccinated, 14,000 vaccination, 4 died, and 2 died of poisoning, one drowned, and 1 had a unknown. But it got a major setback because of the death, and that is how it was not included in the national vaccination program. So I mean, we have to still do many studies in the public. What are the normal minor complications or side effects will be pain, headache, fatigue. Serious and adverse will be the chronic, this is a Guillain-Barré syndrome and chronic fatigue syndrome. These are the major side effects which have been seen. Now, the global regulatory agency continue to monitor the safety. Continuous safety measures are being taken and observed, and studies are being done by WHO, EMA, US FDA. Continuous are done. Global health authorities conclude the benefits of HPV vaccination overweigh the potential risk and they continue to recommend the use of vaccination. Guidelines are there. WHO, UNFPA, FIGO uniformly endorse the vaccination. Now, very proud to say that our president is also here. Foxy has come out with the GCPR and guidelines, which are very well going with the WHO and other guidelines. The same age group, the 45 years, 3 doses, and also 3 doses for 1 to 6 months. Everything is similar. So same guidelines are there. Sexually active women should be taking it as early as possible. Benefit may be limited for the protection against the infection in the genotype. So these are very good Foxy guidelines. They are on the website also and by the IAP also. So in pregnancy, it is not recommended and the patient becomes pregnant, delay in remaining the doses. You are not supposed to give the doses in pregnancy and you are supposed to delay the doses. If the vaccination during pregnancy, no intervention, MTP is needed, and lactating woman can receive HPV vaccine, still continue breastfeeding as it is a vaccine without live viral DNA. So these are the recommendation of the, and what we do, there are 3-4 slides, very important slide. In case of sexual abuse victim, 3 doses are given. Foxy GCPR is for 2018, 3 doses, full doses is to be given. Now, consent is very important. According to the national law, regulation, informed consent, verbal consent, parental consent, social organization can also give the consent, and girl can refuse in spite of parental consent. So, can a person who started 3-dose series with the HPV and 4 HPV complete the series with the new vaccine? There is not necessary that you advise the recent vaccine and who started with the 3 doses. It is not necessary. Then Pap smear still necessary for the women after HPV? Yes, Pap smear is necessary because there are many strains which are not covered and hence you have to follow the patient with the Pap smear. Now, same-sex sexual orientation, yes, vaccine is recommended for the female, male, regardless of their sexual orientation. Immunocompromising condition, as per the WHO guidelines, vaccination should be given in 3 doses, and also in the HIV and malignant neoplasia transplantation, such conditions should be observed and given the full 3 doses. Women are sexually active, HPV vaccine should be given as early as possible. And HPV vaccine can be administered people who are already sexually active. Ideally, patients should be vaccinated before onset. We have already said in our program. However, people who have already been infected 1 or more HPV types still be protected by other HPV vaccines. So HPV vaccine is significantly delayed. Do I start the series over? No need. Do not restart the series. You can should continue from where the patient has left off and complete the series. In pregnancy, contraindicated. And allergy, one who has never had the vaccine, life-threatening allergy, they are contraindicated in this condition. Any other component of HPV and to a previous dose of HPV vaccine where there was an allergy. Illness, if they are very severely ill, then it should not be taken. It should wait for the till they recover. Co-administration can be done in cases of diphtheria, tetanus, pertussis, and hepatitis B. So it can be given. And mild side effects, I already told you, mild fever, itching, moderate fever, headache, nausea, pain at the site, very important. These are minor side effects, not. So does HPV vaccine protect against the STIs? HPV vaccine only protect HPV vaccination and not STI. Safety, I have already showed you the safety slides. 270 million doses were given and they found it quite safe and it overweighs the risk over the safety. Prior routine screening not necessary but recommended if she is in the screening age group. So friends, in conclusion, I like to say that HPV vaccine is a very safe vaccine and it holds the promise for cervical cancer eradication and it should be included in the national vaccination program to save the lives of the women from the cancer cervix. We cannot allow tomorrow to slip out of our hands because of the petty problems of today. And among the most important freedoms which we can have is freedom from the avoidable illness, from escapable mortality. Thank you very much for the patient listening. Hello. Bhagyalakshmi.
Hello.
I have finished.
Hello. Thank you, Mandakini madam, for your excellent presentation on HPV vaccination. Our next speaker is no other than Dr. Nirja Bhatla. She is the professor and head AIMS New Delhi. She was the chairperson of Oncology Committee FACSI, Oncology Committee FIGO, and President AGOI. Now I request Nirja to please give your talk and stick to the time, please. Hello.
Thank you very much, Dr. Janmajay, for your kind introduction. And thank you to Dr. Mandakini, Dr. Bhagya, Dr. Alpesh, everyone who has conceptualized this beautiful program. And thank you to the participants who are here this evening. We recognize how many competing meetings are going on, and we appreciate that you chose to be on this one. So thank you. And I think my slides are with Barsha. If she can start showing them, because I'm not showing the slides. Barsha has to show my slides.
Yes,
I'm having some problem with my laptop, so she will project them. And a lot of my task has been made very much easier by the wonderful presentations by Madam Dr. Usha Saraya and Madam Dr. Mandakini. So I will try not to overlap on any of that in the interests of time. And the topic that has been given to me being about the FOXI GCPR. And as you know, FOXI is not prescriptive and doesn't issue guidelines, but we have what we call as the good clinical practice recommendations. And this, I had the good fortune to be able to put these together while I was the chairperson in FOXI. So this was a very comprehensive GCPR, which deals with screening and management of pre-invasive lesions of cervix and HPV vaccination. Next slide, please. So I want to take you a little bit through the process of making a guideline and to understand it. This is a picture of the various people who came together on the day when we had a face-to-face meeting to formulate. You know, we had a lot of emails going back and forth, a lot of reviews and all. And then one day we had when we were all together. And you can see in this one, Dr. Alka Kriplani, Dr. Bhati, Dr. Anjana, Dr. Mala Arora, Dr. Saraya, of course, is our chief patron who was right there throughout, Dr. Niranjan. So a lot of people came and all the list of experts is there. You can even see Dr. Krishnendu smiling there. It was, you know, I mean, it was all of members from FOXI, from ICOG, from our organizations like AOJ and ISCCP, everyone who works in the field. We've had consensus so that everybody agrees to use these guidelines in the future. Next slide, please. So when we have the process of GCPR development, we first have committee members who select the area of interest for literature review. They give their recommendations with the level of evidence and references, management flow charts. These are circulated to all the experts and discussed first on email. And then I already showed you the face-to-face meeting picture. Next slide, please. So especially for the sake of the students, I have to say that the top, as you know, the best in evidence is considered to be the systematic reviews and the meta-analysis, then the randomized control trials, then the cohort studies and case control studies, then the case reports and series. And although the expert opinions don't rank very high in the grading of evidence, but we did incorporate them in this one because we recognize that there are so many things that we cannot do as per Western standards, because we have to see our patients, our compliance and all that. So this is to show you this accepted level of evidence definitions, level 1, 2, 3, 4, and 5. And I'm not again going to go into this detail. Maybe these slides will be made available to everyone later. Next slide, please. And there is also a grade of a recommendation that ensues. A grade A based on level 1, grade B directly on level 2, or extrapolated recommendations from level 1, grade C directly on level 3 or extrapolated from level 1 and 2, and grade D being the evidence from expert committee reports or opinions or clinical experience of respected authorities or both. So it's important to understand how this recommendation grading is done. When you read the guidelines and you decide whether you do or do not accept to use these in a particular scenario. Next slide, please. Now, in the case of ASCO, before we did this, the American Society for Clinical Oncology had already produced resource stratified guidelines in which they had used 4 levels of resources defined as maximal, enhanced, limited, and basic. And when we first started to make our resource stratified guidelines, we went with these 4. And then we found that they were kind of not necessarily required, and we tuned it down to 3. And then the experts felt that this still is very complicating. And eventually we reduced it just 2 resources, and we termed them the good resource and the low resource. Next slide, please. And recognizing that we ourselves may one day be working in a very good resource setting in a hospital setting with it, which is fully equipped. And the next day, as Dr. Saraya said, we may be going out to do camp somewhere where we have very basic facilities. So we have to constantly juggle hats as we move from the good resource to the low resource. Next slide, please. So this was a modification of WHO guidelines, which helps us to decide what we should really be doing. And if we follow this starting from the left top of the screen, you have to ask yourself, if you're screening by cytology, yes, but is your lab meeting the quality indicators? Is it a good quality cytology? And if it is, can you consider still to add on to your, can your hospital or your patient afford the HPV testing? And if they can, then you should consider whether you should be doing a primary HPV testing, or if you are not very sure about the standard of yet the HPV laboratory, then do at least the co-testing. But of course, if you cannot afford the HPV testing in the present scenario, then you can continue screening with this cytology because it is a good quality cytology. However, if you are not yet started to screen by cytology, or your cytology quality is not right, then you need to think about starting directly with HPV testing. And if you cannot do HPV testing, then VIA is a very good option, VIA alone. And if you are doing HPV testing, then you have to think about how you would like to triage the patients who come out positive. Triage meaning that HPV testing positive does not necessarily mean the patient has any disease. So now we have 3 options to decide who should be picked up for the colposcopy. Either in the high-end scenario, we can do a genotyping and take the HPV 16-18 for the colposcopy. And we can consider doing cytology, or we can do a VIA and see if there is any lesion seen, and we can proceed accordingly. So ideal would be to do the colposcopy and biopsy and give the appropriate management. But sometimes when, in fact, not even sometimes, but many times when the patients are asked to get this done, they default. There is lack of compliance. So there is a great push to think about a screen and treat approach. If it is a small lesion which is amenable, we can do an ablation at the same sitting. We can take a biopsy and send it and do the ablation. The report later will confirm, did we do the adequate treatment or did we not? If it is a colposcopic setting we are doing in and we think it's a very high-grade lesion, we can even do a LEAP, which will give us a composite report and will be therapeutic in many cases. Next slide, please. So these are the criteria of the various single visit approach strategies. And these are all from this little booklet, which Dr. Usha Saraiya also said about. And you can download this from the Foxy website, or anybody who wants it, I can send it to them if they ask it, but you can just do a free download and get all of this. So the see and treat, as I said, is in the colposcopy clinics. If the patient already has abnormal cytology, you know it is likely that she has a problem. The colposcopy score has also told you it's high grade. You can go ahead and treat, whether by excision or ablation. And there's hardly a risk of over-treatment. And later you will have the post hoc analysis. And treat is what we do in the public health programs, typically with VIA, but now we are beginning to talk about HPV, because HPV is the one, as Madam mentioned, which is being recommended by the WHO. And there is a huge effort on to get affordable HPV testing, maybe by GeneXpert, maybe by other methods. So we expect that we will see a situation with an affordable point of care test, which will give the report in an hour's time. And before the woman goes away, we can treat her there and then. Next slide, please. So these are, as I mentioned, we whittled it down to two settings, the good resource settings and the limited resource settings. And we defined what could be the screening tools in each of these. So of course, the good resource has everything, primary HPV or co-testing or cytology or VIA, but the limited resource as of now, VIA and HPV very soon. Then we already mentioned about how we can triage them and the management options, and I will not discuss these again. Next slide, please. And then regarding the modalities which are available, which we have discussed, what is the target age group? So we look at the good resource settings in the first column and the limited resource settings in the second column. And we have kept the target age group in the good resource settings for 25 to 65 years. But in limited resource settings, it starts at 30 years. Now, mind you that in the ASCO, if you look at the guidelines, they say that you stop at 50 for VIA, because in postmenopausal women, we know that screening with VIA is not so effective. But because our Ministry of Health and Family Welfare has kept a guideline to 65, we have retained it so that there is no confusion in the minds of students who follow the guidelines. At the same time, we have put the disclaimer that in postmenopausal women, the screening with the VIA may not be as effective. And the reason for this differential cutoff is that if we look at the data on cervical cancer distribution, we find that there are very few cases under the age of 30. So we don't think that it is cost effective to do universal screening for those few cases. But of course, on a one-on-one basis, when the patient comes with some symptoms or you are suspicious, definitely you should go ahead to screen and see whether she has any problem. So when do you start? For cytology, it is at 25 up till now, until the time when we made this guideline, the HPV testing was being said for 30 years. Now the primary HPV testing by the COBAS test and the Oncology tests have received approval by the FDA for 25 years onwards. So the 25 to 30 has become a bit of a gray zone for HPV, but for VIA, it is 30. And how often? So every 5 years when you put in HPV, if it's only cytology, every 3 years. And the VIA, we don't have so much data to say how often we should do. So it's been kept at every 5 years to align it again with the ministry's recommendations. But if you see the ASCO one, it says at least 1 to 3 times in a lifetime, and that is what we have kept. And further, later to the publication of our GCPR, the WHO recommendation came for HPV testing, which can be done twice in a lifetime at 35 and 45 years, as was already shown to you by Dr. Saraiya. Next slide, please. And when do we stop? So we said 65 years with consistent negative results, and women with no prior screening, you test them once at 65, and then if negative, they can exit screening. This is in both the settings. How do you follow up after treatment? The best is HPV testing, but cytology is the other option, which you can do 12 months later. In limited resource, you can do VIA. You continue the screening for 20 years once they have abnormal reports. And if they had hysterectomy, and if that hysterectomy was for a benign cause, we don't need to screen them unless there's a history of previous CIN. In absence of cervix, you must confirm it. And if the indications are unclear, you can take a call based on your own clinical decision, whether you want to or don't want to screen. Now, the follow-up in women with CIN in the hysterectomy report, that is best done with the HPV again, and it is recommended at 6 months and 18 months. And the HIV positive and immunocompromised women, we say start within a year of initiation of sexual activity, unlike others for whom we usually say within 3 years of sexual activity, and depending on the testing available. And I must say that HPV testing is not necessarily the best for this group, because they have a lot of HPV infection in this group, so it is less discriminatory. So every 2 to 3 years is recommended, but even in limited resource settings, it is recommended that you should do it every 3 years, which means at least twice as often as you would do in the general population. Next slide, please. So here in this slide, you see actually that we have compiled what are the global screening guidelines in practice and what they are recommending. The age to start varies in different guidelines, 21 years, 25 years, and 30 years. And you can see that we have aligned our FOXY guideline with the 25-year for good resource and the 30 years for the limited resource. Next slide, please. So this, as I mentioned earlier, that if you look at the number of cases which are seen under the age of 30 years, there is relatively very, very few cases. And that is the reason why we say it does not need universal. Next slide, please. Now, if you look at the method of screening, again, you can see here the recommendations by various persons and the cytology or co-testing or HPV testing or BIA. And here you can see that our good resource setting aligns with the majority of the guidelines, which are either saying co-testing after 30 and cytology under 30, or which are now introducing HPV testing. And now, in fact, since the time, we have also got UK, which has started HPV testing primary. More and more countries are coming on to that, US and so many others as well. And the next slide. And this is just to show that if you do it at a very young age, there's a very high HPV prevalence, and therefore you would get a lot of false positives if you did it very young. Next slide, please. And then how often you need to do, that is the other one. And while, again, there were some which were annual in the past and none at all now. And even the 2-yearly one, which was being done by the government of Australia, but since they moved to the 5-yearly co-testing now, the primary HPV, sorry, 5-yearly primary HPV. So now that is not. So now there is nobody advising more often that 3-yearly in case of cytology, and 5-yearly with the co-testing, and 5-yearly BIA, which we have put is aligned with the WHO's previous recommendation and the ministry's recommendation. And this just, the graph just shows you how, if you looked at people who were negative on cytology and HPV to start with, there's a considerable number who would be found to have CIN as the years go by, whereas the HPV negative and the co-testing are pretty close to each other at the end of 6 years. And you can see here the rationale for saying that at 5 years, you can safely wait for 5 years, because the risk of getting a cancer by then is not there. So that is what we call the protective effect of the negative test. Next slide, please. So then again, the age to stop screening, which is pretty much 65 years for most people, and a few of them have an older age. I think it partly also depends upon the life expectancy, because you need, this is a slow growing cancer, it takes a lot of time to develop. So by the time they develop that cancer and actually progress, get the infection and progress to cancer, there has to be that time frame. So it depends on the life expectancy of your population also. Next slide, please. And then the post-hysterectomy screening, again, all guidelines have the same, what I have told you. Next slide. Next, please. And then we have this index in this book, which allows you to see the chart number, which will help you to decide how you should manage these patients, which page you need to go to for various scenarios of abnormal cytology, of HPV, of VIA. Next slide, please. So I'm not going to go into the details of each of these. Next slide, please. But this is just to show you that these are the kind of charts you will find if you go and download this resource, which actually you should keep it on your phone and you can just refer to it if it is stored there. Next slide, please. And then again, for the management of the histologically proven CIN AIS, similarly, you will see the chart numbers, page numbers have been defined, as well as a little bit about newer modalities. Next slide, please. And so you have the management of women with each of the stages, the management of those women who are desirous of pregnancy. And the intention is absolutely not that you have to memorize these charts. The intention is to show you each and every possible report that you might get and help you to reach the conclusive pathway. And even the conditions for the screen and treat, the window is there about eligibility for ablative procedures, for example, in the first chart on the left. So that shows you which women you can consider for the screen and treat kind of process. Next slide, please. And this is a little bit about the newer modalities. Next slide, please. And including self-collection, the greatest advantage of HPV is going to be the self-collection. As we move into this COVID era for next 2 years, maybe, I'm not sure how we are going to do all this prevention. We were in the habit of trying to collect people into one place, do so many cases in a day, and I'm not sure how it's going to play out. But I think self-sampling is such a good option in HPV because you can actually send it to the woman's house and let her collect it and send you the specimen, or go to a village and let everyone go into the village. And so many exciting options are there. So I think it's going to be a boost for HPV to do that. The mRNA in general is better as a triage tool, but it has been used in screening. We've not found it so successful yet. And so there's various. Next slide, please. And we have this published now actually as a paper in the Journal of Obs and Gynae Research. We couldn't unfortunately publish it in Jogi because Jogi does not take these type of articles. So they allowed us to publish it elsewhere because it was too long for a small commentary on the Foxy pages. So please, if anybody has a problem securing it, we can definitely give it to them as well. Next slide, please. And another article which we recently published on the primary HPV screening, again, I would recommend that you should read if you are interested to hear. It's a complete update on all types of HPV screening. Next, please. And HPV vaccination has been dealt with in so much detail by Dr. Mandakini and is going to be dealt further by Dr. Patha. So I'm not going to go into this. Next slide, please. But you can quickly flip through the next 3 slides, which show you, next slide, the 2 vaccines which are available in India, because Nana is licensed but not really available. And it's important to register this fact that you, in all the national programs, it is only the young girls who are the target. The vaccine is licensed for older women, but that is never really given in the public programs. And in limited resource settings, particularly, the women have to realize that screening is more important. But even in the affording settings, they have to realize it is not a substitute for screening. Next slide, please. And all these special cases have been discussed already by Dr. Mandakini. Next slide. And this again has been accepted for publication. It's in press now, the vaccination part of it. So it should be out very soon. Next slide, please. And thank you all. You can just click on it, I think, and you'll get my thank you message here. It should not have been an animation, but it is. It's just the last page of the little booklet. So thank you very much for giving me this opportunity and for your patient hearing.
Thank you, Nirja, for your excellent presentation. You all know the cervical cancer is a preventable disease. It is yet to be prevented. Only preventing risk factors can prevent it along with HPV vaccination. It's the call of the day by WHO for elimination of cervical cancer. All the three eminent speakers talked about the basics and prevention of cervical cancer. Cervical cancer prevention is a priority and will be done by screening and vaccination. And both the topics has already been addressed by our three eminent speakers. Thank you, Bhagya, Dr. Arpesh, Dr. Mandakini, and Dr. Parul for allowing me to chair this session. If you have any doubt or any query, any question, you can put the questions to chat box. Answers will be
coming
by email.
It's already coming here. Coming here.
Okay.
Bhagyalakshmi, please expedite.
Okay, thank you.
Audio. Unmute. Unmute, Bhagya. Unmute, Bhagya.
So I think we go straight to the next session. So we have our chairperson, Dr. Priya Ganesh Kumar. Everyone knows her. So Priya, the stage is yours. Kindly go ahead with the session.
Thank you very much. Good evening, Dr. Alpesh Gandhi, Foxy President, Dr. Meg Madam, ICOG Chairperson, Dr. Parag Biniwale, Secretary ICOG, and Dr. Bhagya, Chairperson of Foxy Gynaecologic Oncology Committee. And after the excellent session, we have started with understanding of how preventable is cervical cancer with none other than the stalwart, Dr. Usha Saraya Madam. Then Dr. Meg Madam talking very nicely on and giving excellent advice on vaccination. Further then, we have understood the GCPR guidelines made very beautifully by Dr. Nija and her team, and that has really covered, in fact, all the doubts what a gynecologist has to understand.
I'm extremely sorry, but in interest of time, kindly shortcut your message.
So now we are coming, So now we are coming to the second session. The second section is covering up the first talk on the second session is Colposcopy, step by step, and is management by none other than Dr. Partha Basu. We all know Dr. Partha Basu. He is the group head screening and early detection and prevention section for IR, that is International Agency for Research on Cancer, WHO. And I am very honored to be chairing his session. So over to you, Dr. Partha.
Thanks so much, Priya. Wonderful to see you, even though virtually. So let me try to share my screen. Okay. Hope you can see my screen now.
Yes.
So what I will do is, I have two parts in my presentation. The first part is essentially discussing how to use the IFCPC nomenclature. And the second part, there is a video on large loop excision of transformation zone. So as you know, the IFCPC classification that came up in 2011 actually started being implemented from 2012, is trying to harmonize all the terms that we use in colposcopy, just like, you know, Bethesda classification for pap smear cytology. So I'll just take you step by step through that. So for example, you expose the cervix. There can be two situations. You can see the cervix very nicely and you are confident that you will be able to evaluate. Then you say it is adequate colposcopy. Sorry.
Meg Madam, can we have you muted? So
Okay.
Sorry. Yeah.
And in rare cases, there can be situations like this when the cervix is so atrophied, it is bleeding, you will not be able to evaluate the cervix properly, or there may be a situation in the second picture, as you can see, that the cervix cannot be exposed appropriately. It's essentially because of a cancer there. So this is inadequate colposcopy. So this can be either adequate or inadequate colposcopy. If it is inadequate, then you'll have to make your next plan. But if it is adequate, next we go on to identify the squamocolumnar junction. And based on that, we say what type of transformation zone it is. So if the squamocolumnar junction is fully visible on the ectocervix or at external os, it is type 1 transformation zone. If it is fully visible but partly inside the canal, or fully inside the canal but fully visible, it is type 2 transformation zone. Type 3 transformation zone is when the squamocolumnar junction is inside the canal and it is not fully visible. One word of advice is that always try to identify the squamocolumnar junction after applying acetic acid. So if you see the first picture here, it looks like the squamocolumnar junction is at external os. It's nicely visible. But once you apply the acetic acid, then you can make out part of it actually is going inside. Though you can see, but then it is, instead of type 1 transformation zone, it is type 2 transformation zone. So that is the second thing we need to say, whether what type of transformation zone we are dealing with. Then it can be either you don't see any abnormalities, then you say, I don't see any abnormality, things are normal. If there is any abnormality, then you will have to kind of grade them. Now, the abnormalities are graded into 4 categories: grade 1, grade 2, there is one grade called non-specific, and 4th one is miscellaneous. I have seen many, authors, even from India, when they publish as if the IFCPC classification is a diagnosis. Please remember, grade 1 is not a diagnosis. Grade 2 is not a diagnosis. It is a feature. A single patient may have grade 1 feature, grade 2 feature, and non-specific feature on the cervix. So these are the features, you just categorize them. And how do you categorize? You categorize based on the certain characteristics. I will take one at a time. And please remember, presence of an aceto-white area or a white patch on the cervix by itself does not make it a CIN lesion or cancer lesion. You can see 3 different situations where there are white patches on the cervix. The first one, this one is called congenital transformation zone. You do get a fairly dense aceto-white area. This is seen in about 3% of normal women. This is not neoplastic. This is an aberration of metaplasia. But then the characteristic is the very typical shape. You can see the oblong shape of the lesion, an extension of the lesion to the vagina. So that is important. That is how we identify congenital transformation zone. There can be a condyloma like this. You can see the white, snow white color, and then the location of the lesion inside transformation zone, outside transformation zone. So there is a condyloma. And the third picture you see is that of leukoplakia. That means a white patch that is present even before we apply acetic acid. And all 3 of these are essentially benign conditions, right? Now, let us come to the most important feature, that is the density of aceto-whitening. That will tell you most of the diagnosis. Here you can see it is type 1 transformation zone because the squamocolumnar junction is fully visible, and you see some patches of aceto-white, right? These patches are on the transformation zone, and this is what I would say transparent aceto-white or thin aceto-white. I'll come to SWEET score. So SWEET score, we give 0, 1, or 2 for scoring, for, say, for example, for aceto-whitening. So this will be a typical case of 0 on SWEET score for aceto-white. Now this is one which we call milky aceto-white. When we talk of milky aceto-white, don't think of a glass of milk. Think of spilt milk on the floor. If the milk is spilled on the floor and it is like thin white, So this is why this is the one which we say was 1 on sweet score. And this is the dense acetohyte, which is a 2 on sweet score. So this is by acetowhitening of the lesion. The next characteristic, I'm sorry, there's of course, this is also a type 2 acetowhitening. There's a thick, dense acetohyte, the area that we see in the invasive cancers. So looking at the density of acetowhitening, we can say whether it is a grade 1 finding or grade 2 finding. So this one is a grade 1 finding. It's a thin acetohyte. This is also thin acetohyte, grade 1 finding. As soon as we get this kind of dense acetohyte or like this, this one is grade 2. And when we see this kind of thick acetohyte, it makes us suspect invasive cancer. So depending on the density of acetowhitening, we can grade it, we can do sweet score. And the next important thing to look for is the margin of the acetowhitening. Here you can see the first picture. This is again squamocolumnar junction is nicely visible, type 1 transformation zone.
Is not able to see.
Is it okay, Bhagya? Can you hear me?
Dr. Bhagya, can you mute yourself?
Okay, so here you can see some white patches here and there. So here are some white patches. But if you try to identify where is the outer border, there is no definite outer border. There is no margin. It's a very indistinct margin. Again, here you see a thin acetohyte area and some more whitening here and there. But then when you try to look for the margin, part of it has a margin, rest of it does not have a defined margin. So from margin point of view, if you want to put the sweet score here, it will be 0 for the first one. For this one, at the most, it can be 1, or even you can say 0. It is in distinct margin. But then here it is, what you can see is, you see the acetohyte lesions on the anterior lip as well as in the posterior lip. In the anterior lip, the margin is definitely very well defined. You can actually draw the margin, but it is very irregular, very angulated margin. So whenever you see this kind of irregular angulated margin, which makes the sweet score 1, it tells you that this is at the worst can be a CIN1 lesion. Most of the time, these are flat condylomas, and particularly this lesion is flat condyloma. Why? We can see this lesion here with irregular geographic margin, and we see the satellite lesions. You see those satellite lesions, they are like islands on the ocean. Whenever we see this kind of feature, we know this is flat condyloma. So this is the irregular geographic margin for which we usually give sweet score 1. And this is the margin when we can see a dense acetohyte area with a very well-defined, very clear-cut margin. And this is 2 for margin. And but then this margin is not yet elevated from the surface. This is a lesion which you can see a dense acetohyte lesion, and look at the elevation of the margin, both on the anterior lip as well as on the posterior lip. So as soon as you get this kind of lesion, which is a large lesion occupying almost the entire cervix, with the margin elevated, it is of course sweet score 2, but then start thinking of invasive cancer. In fact, this was a microinvasive cancer. So distinct raised margin is sweet score 2. Okay. Now, rapidity of appearance of the lesion. Sometimes you keep on applying acetic acid, and after maybe 15 seconds, 20 seconds, you get to see a thin acetohyte lesion. Then you know that is at the worst, that may be a low-grade lesion. But then the high-grade lesions, you will invariably see, you touch the cervix with your swab, and in 5 seconds, you get to see this kind of dense acetohyte area. So that tells you that this is a significant lesion, high-grade lesion. In fact, this was an invasive cancer. You can see the large lesion, dense acetohyte, some, you can see the coarse mosaics here. So how fast the lesion is appearing, that tells you whether it's a low grade or high grade lesion, though that is not considered either in the SWID score or in the IFCPC classification. Now, the location of the lesion as compared to the squamocolumnar junction, that also is very important and helps us to say whether a lesion is significant or not. Here, of course, you can see the squamocolumnar junction very nicely, and you see a dense acid-white area. But then look a little bit more closely. You can see there is a distinct gap between the squamocolumnar junction and the acid-white area. And look at the very angulated geographic margin of this acid-white area. This tells me that this is a flat condyloma, because flat condylomas have this kind of angulated margins. They have this kind of, as I said, satellite lesions, and they are away from the squamocolumnar junction. So remember, lesion which is high-grade lesion particularly will always be arising from the squamocolumnar junction. Exactly as you can see here. Here you can see a lesion which is arising right from the squamocolumnar junction. Part of the lesion is inside the canal. And then you see the dense acid-white lesion, 2 for SWID score for color. You can see the very well-defined margin, 2 for margin on SWID score. Now on SWID score, there is another thing, that is the size of the lesion, which was not there with Reed score. People keep asking, what is the difference between Reed score and SWID score? There are 2 essential differences. Number 1, Reed score was applicable only if you see an acid-white area on the cervix. If you don't see acid-white area on the cervix or abnormality on the cervix, don't use Reed score. But SWID score is for every cervix. Even if it is a normal, you'll have to give a SWID score. So your final diagnosis will always come up with a SWID score. That is number 1 difference. And number 2 difference is that in Reed score, there was nothing for size of the lesion. Here there is the scoring for size of the lesion. So you can see this lesion. This lesion is essentially in the posterior lip. It is taking at least 2 quadrants of the cervix. So this is on SWID score, we give a score of 1. So if the lesion is occupying 2 quadrants of the cervix, or occupying less than 75% of the cervix, we say it is 2. So that's the only that is the difference between Reed score and the SWID score. Now, among the grade 2 findings in IFCPC classification, you'll see inner border sign. This is a little confusing word. So what is inner border? You can see this cervix, there is a large acid-white lesion, which is relatively thin. And within that large acid-white lesion, you can see a dense acid-white lesion. And because of the difference in color, we get the inner border. So this is called inner border sign, which indicates that the inner lesion is always high grade. So that is something, a grade 2 finding on IFCPC classification. Another grade 2 finding on IFCPC classification is called ridge sign. This is a very classical case of a picture of a ridge sign. You see the dense acid-white lesion with a very distinct margin, in fact, a little elevated. And you see this ridge-like or table-like things that are going towards the external os. This is telling me that this is definitely a high-grade lesion, can even be an invasive cancer. So yeah, so ridge sign is a grade 2 feature on IFCPC classification. And there is another grade 2 feature on IFCPC classification that is called significant crypt opening. So if you see the picture on the right, this is probably a normal crypt opening where you see the black dot and then surrounded by a thin rim of white. But then if this thin rim is more dense, raised from the surface like this one, or on the left-hand side, you can see this, crypt opening, which is significant. So a significant crypt opening is another grade 2 finding, and it suggests high-grade lesion. Punctations. All of you know, if we see this kind of red dots on the cervix, if they're fine, if they are all over, essentially they indicate inflammation, quite common. So this is not significant. This is a fine punctation is a grade 1 finding. And in terms of sweet score, if you find fine punctation, then it is 0. The score is 0. The moment you see coarse punctations like this, you can see the dots are much more prominent. That is a grade 2 finding, and the sweet score immediately becomes 2. And then there is another vascular finding that's called mosaics. Fine mosaics, when the mosaic pattern is, it is like very, you can actually trace each blood vessel, and then they are very regular. Or it may be sometimes like this, looks like a few tiles somebody have scattered on the floor, and in the background of a thin aceto-white area. So this kind of fine mosaic is essentially found in squamous metaplasia. It's again a low grade or grade 1 finding on IFCPC. If you are doing sweet score, the sweet score is 0. Please remember, a fine mosaic, fine punctation is 0 on sweet score. But if this was a white patch without any fine mosaic on this, the sweet score would have been 0, because fine mosaic indicates this is metaplasia. If it is an opaque lesion, that is at least a CIN lesion. So that's why 0 is for fine mosaic or fine punctation. And here you can classically see what is coarse mosaic, a grade 2 finding, and on the sweet score it is 2. You can see the very irregular mosaics and all over the cervix. In fact, both of these cases were invasive cancers. Now, abnormal or atypical blood vessels. The term we use in IFCPC is the atypical blood vessel. Typical blood vessel is when you see a nice branching pattern. As soon as that kind of branching pattern is lost, that is atypical blood vessel. So here you can see very typical blood vessel, a central stem giving out branches. Sometimes it may be like a root, but then still you can see the branching pattern. Sometimes it can be very confusing. You can see the blood vessel here. It does have a branching pattern, but then sometimes it looks like irregular. So always remember, it is very, very difficult to identify atypical blood vessels. So always go for the background. If the background is dense aceto-white with the irregular surface, and you see this kind of, these are the atypical blood vessels, absolutely bizarre shape, tadpole-like. This one is Chinese character-like. So this kind of bizarre shaped blood vessels on the background of a dense aceto-whitening, surface is irregular, surface is bleeding on touch, that goes into the category of suspected invasion. So that is a third category on abnormal IFCPC. So grade 1, grade 2, suspected invasive. This is the suspected invasive. And always atypical blood vessels are scored on sweet score as 2. Again, if you see a lesion that has started having irregularity of the surface, as you can see here on the left, you can see the picture before applying acetic acid. Even before applying acetic acid, you can see the coarse punctations. You can see the surface irregularities. This we call molehill-like appearance, small hills. Then be careful that this is an early invasive cancer. This is a very typical feature of micro-invasive cancer, very early invasive cancer, surface irregularity. Sometimes if you are doing if you have a really good screening program, or if you are using HPV testing, you may land up diagnosing this kind of very early cancers. You can see the cervix, almost the entire cervix is normal, a bit of erosion here, but then this you can see the dense aceto-white lesion within the canal almost, and the irregularity of the surface. You can see again molehill-like appearance, and you can see the small atypical blood vessels. So this is suspected invasive cancer on IFCPC classification. Now, I said there was a fourth classification, that is non-specific. One of the very common non-specific finding is erosion or peeling off of the epithelium. You can see a dense aceto-white area all over the cervix, And of course, all of you can diagnose it very easily. You can see the coarse mosaics, you can see the coarse punctations, and you can see part of the epithelium has come out. And this is a very typical picture of high-grade lesions or invasive cancers. But then erosion can be because you have because of the trauma from the introduction of the speculum. It may be because of inflammation. So that is why erosion has been put as a non-specific finding, because it can be associated with cancer. It may be associated with purely benign condition. Similar non-specific finding can be iodine negative area. As you know, if it is a postmenopausal cervix, you will get iodine negative areas. But then the CIN lesions are cancers are also iodine negative. So that's why this goes as a non-specific finding. Here you can see the metaplastic area that we had, the grade 1 finding or whatever, thin acetowhite area that has not taken up Lugol's iodine. So it really does not tell me much. What is important is if there is an acetowhite background and that same acetowhite area is uniformly iodine negative, giving the typical canary yellow color, that tells me that we are dealing with a high-grade lesion. And essentially, the most important application of iodine, Lugol's iodine application is during treatment. You know exactly how much of transformation zone to be treated. Just like here, you can see the dense acetowhite lesion. You really do not know how much is the transformation zone extending to. Apply Lugol's iodine and see the very nice area that you need to treat with loop excision. This is something we don't get to see too much because we don't have good quality cytology in most of our centers in India. But if you do have a cytology-based screening program, you do pick up glandular lesions. So glandular lesion is a lesion that is there on the columnar epithelium. You can see till now we were all dealing with squamous lesions. Now here you see a dense acetowhite lesion, little elevated on the columnar epithelium. This was adenocarcinoma in situ. On the columnar epithelium, if you get all the features of invasive cancer, like dense acetowhite, irregularity of the surface, very typical parallel atypical blood vessels. You can see the parallel atypical blood vessels, then suspect invasive adenocarcinoma. Having said that, this is one of the most difficult diagnoses, right? So now we come to the SWEET score. So what are the things we look for? Exactly as I said, we look for, as we used to do for read scoring, we look for acetouptake, we look for margins, surface, vessels. This is the one which is the new thing, and iodine staining. And based on that, you give a score, you calculate. Now that's the most important thing. Now, if the SWEET score is less than 5, there is very little chance that the woman will have a high-grade lesion. So you can send her home. You may, at the most, you may go for a biopsy, but you never treat that woman immediately. But then if it is 5 and above, there is a possibility of a high-grade CIN, especially if it is 7 and above. There is definitely a very high risk possibility that the woman is having a high-grade lesion or cancer. So we do colposcopy. We classify the features by the IFCPC classification. That's not a diagnosis. Then we do the SWEET score. Based on the SWEET score, we finally say, I am dealing with a normal woman. I am dealing a woman who has probably a low-grade lesion. I am dealing with a woman who probably has a high-grade lesion or an invasive cancer, right? So next, hope this will work. So I'll quickly show you a video of doing a loop excision. I think Dr. Uma is here. She'll remember this was a case that I was doing in Lucknow Foxy conference, and she was the chairperson. So I'll try to just fast forward things. Most important thing is that if you detect a lesion, you can do, as Dr. Nija said, that see and treat. That you are seeing a high-grade lesion, you immediately take out your regular speculum. Please look at the speculum. That is most important. The speculum, I am not a big fan of the insulated speculum. It is really not necessary. What is necessary is the speculum should have this smoke extraction channel. You see the pipe at the top. you must connect your usual the usual suction machine to that. Now, you expose the cervix well. That is important. Make sure that the vaginal wall is not coming in the way. You can see that there is a dense acetowhite lesion in the posterior lip. You can see the coarse mosaics there. It has a very well-defined margin. It was actually a CIN2 lesion. Now, what we need to do is to apply local anesthetic. We don't have to do paracervical block. We don't have to do any general anesthesia or anything. You just directly, inject the epithelium. Take 5 ml of 2% aceto, 2% xylocaine, add another 5 ml of distilled water. So you have about 10 ml of 1% xylocaine. Take the other one spinal needle. If you are lucky to have a dental syringe and needle, then you can use that. Or otherwise, I used to use this kind of spinal needle. It works reasonably well. Inject all around, but avoid the 3 o'clock and 9 o'clock position. And as you can see, if you are injecting this thing well, you get to see the cervix. It is becoming less vascular because there is adrenaline in that. And so you inject the local anesthetic all over. And then after injecting, what is most important is that give the patient some time. Don't immediately jump onto doing the excision. So that is the time. You see you choose your loop. You need to choose a loop that is adequate for the type of excision you want to do. As a type 3 excision is when we need to take out quite a bit of endocervix, which is when the type of transformation zone is type 3. Here we could see the squamocolumnar junction nicely. So maybe a 12 by 15 millimeter loop will be good enough. I don't want to take a huge chunk of the endocervix in this woman. And start with your, and then this is the time when you set up your diathermy machine. So usually I start with 45-45 cutting and coag combination, but each machine is different. So whoever was there told me, try with 50. I said, okay, let me try with 50. So we do that, but use the combination of coag and cutting, right? So now you can see, and don't use too much of magnification. You need a good panoramic view to see where your lip is moving to, right? Now, next thing is try to see which way you want to go. You want to go from side to side, or you may want to go from below up. Either way, it is fine, but never try from the top and don't try to go towards the bottom, because the tissue will fall on your loop and your loop will not advance. So this is what I call, blind passes. Just give some blind passes to see that, vagina is not at risk. So you do that, and then, I'm sorry. So start from beyond the lesion, and I always prefer to start from the more difficult part. You can see this side, the lesion is very close to the vagina. So grow from there, go slowly and steadily, use full depth of the loop. That is important. And then when you come out, be careful, because that is the time when most of the vaginal injuries happen. So you do that, and and then take it out. It is better to use usual forceps, but then I didn't have. So if you do it slowly, deliberately, there is very little bleeding, and you can change your loop to a ball electrode and try to coagulate those bleeding. So you do that, but then in this case, there was still a little bit more lesion left behind. So you can go for the second pass. But always remember, first take out the central part of the transformation zone. That is the most important. And then you may go for second pass and then take out any leftover lesion that may be there. And please do not remember two things. Send this specimen for histopathological evaluation to exclude invasive cancer. And second, the woman should be followed up after 1 year. And that's very important. I'll stop here. Thank you very much.
Thank you very much, Dr. Pata. Pata, it is always a wonderful treat to learn from you. And most of the candidates out over here would have been benefited. You have been, your slides have been really good. I mean, IFCPC nomenclatures and those pictures which you had brought were really excellent. Now,
and there are many
so
questions. Please, Partha, please go to the QA box and please answer them for us. So thank you very much again.
Yes. So now, should we go to the next lecture or should we be answering the QA? I think we can answer it later on, isn't it?
Yes. We have no time for the questions, so they'll be answered.
Yeah. So now the next lecture was to be taken by Dr. Amita, but now I do not know, but we have our sweet Nirja with us, and Dr. Nirja is going to take us through the new FIGO staging and implications. Dr. Nirja doesn't actually require any introduction. She is a stalwart, and she is, over to you, Dr. Nirja, for your wonderful deliberation again.
Thank you very much, Priya, and thank you once again. It's because Dr. Amita was not able to, and as I mentioned earlier, I have a lot of problems with the laptop, but I did manage to find one presentation which can work. So I will again request Barsha to please share the presentation which I have mailed to her.
Yes, ma'am.
And this was the product actually of my term as chairperson in in the FIGO Oncology Committee. And just to share once again the process of revising the FIGO staging. Next slide, please. Next. When we look at cancer staging, we must understand what is the purpose of a staging system. It should describe the extent of the disease, help in planning treatment, predict the prognosis, evaluate treatment response, and guide the research. Next slide. It's very important that it should be applicable in different resource settings. The skills required for staging must be achievable. Investigations should be affordable and should aid considerably in the management. Next, please. Now, FIGO's perspective on staging, it skipped one, is that basically FIGO caters to the entire, all kinds of resource situations, the previous slide. And it is important for FIGO to have everybody on board. And in the case of cervical cancer, previous, it is, sorry, I think it's my mistake. Next slide, please. Yeah, this one. So in the case of endometrial and ovarian cancers, the mainstay of treatment is surgery. So even if patients don't have access, but the ones who do get the surgery done, and it was easy to change that from a clinical to a surgical-pathological. But in cervical cancer, firstly, mainly in low resource conditions, and secondly, when they come in advanced stages, as we have been hearing, radiation is also an important treatment option. And so the staging continued to be clinical right up to the last revision of 2009. Next slide. So it was decided that we would look into this staging, and this I did along with my various committee members, which, as you can see here, it's people who are from all parts of the globe, and they represent all the ethnic and racial diversity and the gender diversity as well. So these were the various people who were involved as participants in this program. It was Kanishka Karunaratne, who was the co-chair, Shea Grenman, who was the ex officio person, and then we had Dr. Shankar Ikuo Konishi from Japan, Jaime Pratt, the pathologist from Barcelona, Lynette Denny, the past chair from South Africa, Alexander Olawaye from the US, who also represents AJCC, Dr. Jonathan Berwick, all of you know, no introductions needed. He's a stalwart from Stanford, and Mauricio Coelho, who is from South America. Next slide, please. So the first meeting we had, in fact, Dr. Bharti had organized the FOXY FIGO conference in Pune, and that is where we had our first FIGO Oncology Committee meeting. And we decided then that we really have to consider about bringing lymph node status into the staging. Imaging techniques have advanced considerably. Surgical approaches and extents have changed, and at the time there was considerable use of MIS, which was increasing. Of course, now recently the LAC trial came and showed about all the problems with doing minimally invasive surgery, but at the time minimally invasive surgery was just increasing exponentially. So the main concerns that were expressed by people were, oh no, again a change, and how will the basic levels participate, because they don't have all the facilities for imaging, for MIS, and so on. Next slide, please. So now what we realized was that the imaging capability having increased significantly globally, though it is lacking in many regions that bear the burden of cervical cancer, but also in these regions, there are parts that have very advanced imaging technology. And image-guided FNA is also being practiced at several centers. And the increasing use of fertility-sparing surgery, the radical trachelectomies, had brought a lot of data on the correlation of the size of tumors with the outcomes. Next slide. So the questions that were before us were, should this continue to be clinical? Should we include lymph node status and pathological findings on tumor size and staging? Should we include imaging and staging? And then, since it was seeming so difficult to get consensus, there was even a question being asked by some of the Western societies, should we just go and have different stagings for different resource settings, which was obviously not an option. Next slide, please. So the data on stage-wise survival has been around for a while and is very clear. And indeed, the curves should separate stage-wise, otherwise the staging is not serving its purpose. Next slide. The accuracy of clinical staging, however, did have a significant error rate ranging from 24 to 39%. And if you looked at it by the exact stage, it was more accurate in the early stage 1A1 to B1, and the higher the stage went, the more the accuracy declined. And without the cross-sectional imaging, there was, of course, a very poor evaluation of deep pelvic invasion. Next slide, please. So with the clinical staging, you could not address significant prognostic factors like tumor volume, nodal metastasis, stromal invasion, lower uterine segment involvement. Next slide. There was this meta-analysis by the Gynaecology group, which showed that there was a clear prognostic value of nodal metastasis. And we all knew this, except that we said the prognosis altered, the stage doesn't change. But they showed very clearly that para-aortic node status and pelvic node status were significantly associated with progression-free survival. Next slide. And the prognostic value of the tumor size as well. Next slide. And the risk of parametrial spread in small tumors had also been assessed. And the risk of parametrial spread for tumors less than 20 mm and with no LVSI, with a depth of invasion within the third, was found to be very low. Next slide. So, of course, with involving imaging, the use of procedures like cystoscopy and proctoscopy was being diminished. And because of this identification of prognostic factors, there was the possibility not only to up or downstage the disease, but very importantly, to avoid multimodality treatment. Now, many times you might find that the patient intra-op was found to have nodal involvement or significant LVSI based on the pathology, and then sent off to radiation, which means that it would not necessarily impact her survival, but you would find that because she received this multimodality treatment, she would have a greater morbidity, a greater impact on quality of life, a greater impact on financial implications, and so on. So this is a very important thing to keep in mind, that we should choose the one modality that is most appropriate for this patient. There are also definitely less radiation side effects when it is planned without hysterectomy than when it is a postoperative adjuvant radiation, as well as the fact that when the tandems can go deep into the uterus, the kind of isodose curves that can be generated are very different from what is when half the vagina has been taken off. Next slide. So if you look at the incidence of cancer cervix, and this is the Globocan 2018 that was referred in the first slide itself, you see that it's almost as though south of the equator we see most of the disease, and the vast burden in areas of Africa, Asia, and Latin America where resources are less. Next slide. And this is what has been clearly shown in the IARC database as well, that there is a much higher, this is the world average in the center, and you can see that these areas are far higher above. Next slide, please. Next. And then the question of the adequate imaging facilities, which sometimes even in OECD countries are not necessarily very widely available. Next slide. And in countries like Africa, of course, where there are very few radiologists and very few pathologists, it is definitely a problematic situation. Next slide, please. Then again, dilemmas in imaging include that if there are enlarged nodes, these may be infective, especially this is true in HIV endemic areas. And stromal invasion may not be confirmatory by imaging. PET-CT may also not be confirmatory. And the cytology, histology, so we need more and more resources. Next slide. So anyway, we went through the whole gamut again of a committee proposal, which was reviewed by the major gynae-onc societies. And then we had a face-to-face meeting when we had the first FIGO regional meeting in Dubai in April 2018. And finally, we presented it at Rio conference in 2018 October and published it. Next slide. So these are the various participating organizations, which are what are typically termed the sister societies, who have always been participating. But I'm happy to say that I was able to involve in a considerable way the AGOI leadership, as well as other societies from Indonesia, as well as in South Africa and RCOG as well. Anybody and everybody who wanted to be involved was involved. And we also had the Cervical Cancer Research Network and GCIG giving their valuable inputs onto all of this. Next slide, please. We also had a lot of meetings which were held at on the sidelines of various conferences, where we used opportunities for face-to-face discussion, teleconferences, etc., to bring consensus to the table. Next slide, please. So finally, we came out with this, and the salient features are that it is applicable to all resource levels. It gives you the option to use a clinical or imaging or pathological finding. There is an additional cutoff which is introduced at 2 centimeters in stage 1. And so you have a 1B1, 1B2, and 1B3. And any lymph node positive is stage 3. Next slide, is stage 3C. So in the stage 1A, the main thing was only that the lateral spread has been removed. It was because there is no consistent evidence that this lateral spread has any correlation with the pathological lymph node and all those findings and the survival. So there have been some people who have been protesting it, but there is no significant literature to support it. Eventually, there should be literature. Next slide, please. And then, as I mentioned about this 1B2 cutoff, next slide, please. Next, please. And then these were data which were coming from various radical trachelectomies, as I mentioned, which showed that the most important risk factor was the size of the lesion. 10% of the patients had lesions which were more than 2 centimeters, but they represented 50% of the recurrences in Mary Plante's series. Next slide. Similar data was coming from other studies as well. Next slide. Next slide. So there was a good level 1, level 2 evidence for this one. Next slide. And of course, the controversial part still remained that the LVSI does not change the stage. The involvement of the uterine body does not change the stage. Next slide. In stage 2, broadly speaking, the same, except that you can use imaging now to determine these things. Next slide. And now the utility of imaging here is less clear for evaluation of the parametrium and the upper vagina. MRI is somewhat better, but there are still false negative and false positives, especially when there is infection or with large tumor size and stretching of the upper vagina by the growth. Next slide, please. And then stage 3, as I said, is a major change, that anything that was looking like 1 or 2, but you have nodes, whether by imaging or by pathology, it goes to stage 3C. It's C1 with pelvic nodes, it's C2 with para-aortic nodes. If this decision is based on radiological findings, it is termed R. If it is based on pathological findings, it is termed P. Next slide. Next, please. Again, we have good level 1 evidence for this one. Next slide. And there were several studies available for this purpose. In interest of time, I will go through very quickly. Next slide. Next slide. Broadly to say that you can use more or less whichever method of imaging you have, there are merits to each. Next slide. So these are the ones showing you that that whichever method is used, the correlation and relationship to prognosis is shown. Next slide. And then there were even studies to support that the transvaginal sonography and the transrectal sonography in capable hands could compare well with the MRIs for local staging. And this was actually pushed most of all by the European group, who have had several papers in this direction. So it is not only that you must have the high-end machines. Next slide, please. Next. 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 So the one thing was the isolated tumor cells or micrometastasis, and then we initially kept this as not changing the stage, but subsequently there were a lot of data shown by people on micromets, and in the corrigendum, we have now moved micrometastasis to qualify for stage 3C, although the presence of the ICTCs does not qualify for stage 3C. Next slide. And sentinel nodes, again, because there is not yet enough data, is not a recommendation to be used necessarily in cervical cancer. Next slide. Next, I think we've discussed all these, so I will just go on to the next one. Next. And then the stage 4, which remains unchanged again, except that you can use imaging to guide this. Next slide. So the summary of the revisions is that you can use any imaging modality or pathological findings. You can record R or P accordingly, and the various stages I've already mentioned, but it removes the previous recommendations also for routine investigations, what was termed as routine investigations. Next slide. So it adds immense flexibility to the staging, permits its use in all types of resource conditions, places considerable onus on the clinician to assign the appropriate stage. For example, you see in large nodes on an MRI, you have to decide, do you think they're infectious? Do you think they're caused by the malignancy? And you take a call accordingly on whether you consider it or not, and you place the staging. But it has implications, therefore, for the radiologists, the pathologists, the radiation oncologists. And as we go forward, the future publication of systematic data as well as retrospective analysis of data sets is being brought forward to show us the validity of the staging. And most importantly, from India, we must collect our data and publish it to be able to inform the future stagings. So next slide. With that, I thank you once again for your very patient hearing with some glimpses of the Dubai meeting. Thank you.
Thank you very much, Dr. Neja. It was really, truly a wonderful deliberation. And to listen to you about the making of the new historical figure classification is really wonderful to listen to you. And understanding of the figure classification has become more easier. Now we move on to the next talk. The next deliberation is by Dr. Bhagyalakshmi, who is going to tell on surgical anatomy of pelvis is what we are going to understand from Dr. Bhagya. She is holding the position of Associate Professor, Gynae-Onco Chairperson, Oncology Committee of FOXI. And also she is coming from her institution, AH Regional Cancer Center, Cuttack. So over to you, Dr. Bhagya.
Please share my screen. Thank you. So thank you, Priya. Am I audible?
Yes, yes, you are definitely.
Yeah.
Kindly
So
go ahead.
surgical anatomy of the pelvis, I think it's quite a end of the day after so much deliberations, but still we have to go through that because it's very, very important. So I think anatomy was written way back in 1543 by a Belgian-born anatomist who was the first one who had a lot of interest to know what is inside the body, and he actually dissected many bodies and started writing anatomy. So I think anatomy is the father of surgery because without knowing anatomy, you can never do a good surgery. So, and anatomy has been revised. So anatomy has been revised many times with the advent of high-tech we have good now visions, we have robotics, we have laparoscopy. So people have started seeing anatomy in much better perspectives. So there are many variations have been detected and rectified, but there are three landmarks which have always been there: the round ligament, the psoas muscle, and the external iliac artery, which have never changed since the ages. So these are the three fixed landmarks which we have to remember always. So I think some problem, I cannot move my slide. Mr. Raghu?
Kindly click on your slide, madam.
Sorry?
Kindly click on your slide and move.
Okay. So I think we need to know the way. So even if you know the way, so even in difficult situations, if you are aware of the situation, you will be, you can find your way out if you know the anatomy well. So one is a descriptive anatomy, which we have studied way back in our MBBS class. Then as we start doing surgery, we develop the acumen of learning surgical anatomy. But the most important of everything is predictive anatomy, which comes with knowledge and practice, and not only practice, but a perfect practice. So this is very important, especially when the anatomy is distorted. And because as you will all know that all simple surgeries could be unindicated. When you think you have done a very simple NDVH, it could well be unindicated at all. So the most surgeries, if you know the landmarks, even in a dense forest, you can find your way out. So the only difference between benign and oncology surgery is that most of the benign surgeries are done intraperitoneally, but a retroperitoneal dissection is required when you are doing a oncological surgery, and that is little risky and tricky. So we have to learn that before we start doing. So the anatomy of the pelvis merely has the pelvic ligaments and the retroperitoneal spaces, the pelvic vessels and nerves in the side walls, and the visceral structure. So these are basically the things. So we have essentially 5 pelvic spaces and pelvic ligaments. So these spaces are divided by the pelvic ligaments. The pelvic ligaments are all condensations of the fascia, and the pelvic spaces are all avascular spaces. So God has been very kind to us to give us avascular spaces so that we dissect into these spaces and find out all the important structures that are there, and hardly there is any bleeding. And so whenever you start your surgery, so this is the uterus, which is usually held. When it is pulled to one side, whatever comes into view, the round ligament anteriorly and the IP ligament posteriorly. So this is the broad ligament, and it's otherwise also called the adnexal triangle. So you can see it's a triangular space which is bounded by the round ligament anteriorly and the IP ligament posteriorly. So this is our window into the retroperitoneum. So once you incise this space, we divide the broad ligament into an anterior and a posterior layer. So here you can see that the posterior layer has been held, and you can easily see that the ureter is embedded in the posterior layer of the broad ligament. So, but it may not be always so easy to find, especially when the woman is obese. But this is the general position of the ureter on the posterior layer of the broad ligament. So once you open the retroperitoneum and start dissecting, the other structures that come into view are the psoas muscle, the external iliac vessels on the lateral pelvic wall. So these are the next things that come into view. So this is again a schematic diagram to show you that this is the lateral pelvic wall. And sometimes if you have enlarged nodes, they can show up like this. So, and once you have pulled the uterus to one side and the retroperitoneum is exposed, so you can easily enter into the spaces, paravesical and the pararectal spaces. So here you can see that, and especially when you are doing a laparoscopic surgery, laparoscope with the pneumo, half your job is already done because the avascular spaces open up by themselves. And the same thing here is by open surgery. So, but but it's easier because the spaces open up fast. So all the structures, important structures in the pelvis, they traverse from anterior to posterior. The only one important structure that traverses from the lateral to the medial side is the uterine artery. So all the pelvic vessels, the ureter, everything traverses from anterior to posterior. So the dictum is to dissect along the parallel to these important structures, and the only thing which traverses from medial to lateral is the uterine artery. So we have to be careful about that. And sometimes you can, with good laparoscopic surgery, you can see the levator ani muscle also, because the spaces are avascular and open up by themselves. So here you can see the up to the pelvic floor, and these are the spaces they have opened up. There are no vessels, it doesn't bleed. And so these are the external iliac vessels, and these are the adnexa which have been pushed to the medial side. And this is the Meckenrot's or the cardinal ligament, which is a triangular structure with the apex towards the uterus and the base on the lateral pelvic wall. So this is the structure which has to be removed and the ureters dissected so that we can put a clamp as lateral as possible. So the ureter traverses under this Meckenrot's ligament. So when we have to identify the ureter, we remove the tunnel so that we can place the clamps as lateral as possible. Here you can see the clamps being placed as lateral as possible. So this is again another picture. Here you can see that we have already exposed all the spaces. You can see the cardinal ligament, the ureter, the uterosacral ligament, and identify the uterosacral ligament. And here you can see that the clamp has been placed so posteriorly. So this is type 3 radical hysterectomy. So again, the division of the vesicocervical ligament. So here this is the vesicocervical space. So this is again a vascular space, and here whenever we are doing a vertime hysterectomy, we have to go deep down up to the upper third or upper middle third of the vagina. So this is again a vascular plane, but occasionally the bladder pillars, which sometimes the ureter tunnels through the bladder pillar, they may be vascular and bleed. So this is how we go there. So the Dinan-Villiers fascia is another important fascia when we dissect through the rectovaginal space. So this is named after a French anatomist. It basically has two layers, is a vascular plane again. And whenever we are dissecting through this fascia, we have to remember that fat belongs to the rectum. So we leave the fat so that we avoid any incidental injury to the rectum, if you remember that the fat belongs to the rectum. So here is the space by which we have, you can see that we have entered into the rectovaginal space, and have to remember that again, this is also a vascular plane. So we have to go divide the vagina from the rectum because we have to go beyond the disease. So having done that, again, you can see yet another ligament, which is again a triangular ligament, a fan-shaped ligament, and that's the uterosacral ligament. And you can see that the uterosacral ligament divides the pararectal space from the rectovaginal space. So this is a triangular ligament, and most of the fibers, though named uterosacral, actually they end on the rectum. And this is very important because most of the nerves traverse through this uterosacral ligament. So we have to be little careful in clamping and cutting, and also they are very vascular structures. So this is again the uterosacral ligaments. Here you can see these are schematic diagrams. So here we have put the clamp as lateral as possible with the uterosacral ligaments after dividing it. So this is again another picture in which you can see obturator lymphadenectomy is being done. This is the obturator space, the cord-like white nerve on the right lateral side. And once you push the external iliac vessels, the obturator fossa comes into picture, and you can see the obturator nerve, which is a thick nerve and is a motor nerve. So we usually hardly it's injured, and the nodes and the obturator vessels all lie along the obturator nerve. So the nodes have to be teased away from this obturator nerve. So here you can see a more clearer picture about the obturator nerve, arteries, and the veins. So the essence of everything is we know the anatomy, be gentle to the tissues, and so they are also gentle to you. So this is a picture of the end of the surgery when everything has been removed. You can see the ureters are lying bare. You can see the pelvic vessels on the lateral pelvic walls, and the vault which is being held by the sutures. So this is a small clip. I think we'll go because Dr. Gary will be showing you the video. So this is again a site of the internal iliac artery ligation, which we would do whenever there is a profuse bleeding in cesarean section or in any pelvic surgery. So this is the area of the internal iliac artery. Here you can see the anterior division and the posterior division. The posterior division actually dips down and goes to the parietal, supplies the parietes. So we don't need to see that or dissect that. So this is the cross is the area of the internal iliac artery anterior division, where we usually put the knot to prevent the PPH. So the internal iliac artery has a posterior division and anterior division. The anterior division has uterine, these are all visceral vessels, and the posterior division, as I've already told, are mostly supplied the parietal wall. So the uterine vein is again an important structure and has to be remembered that usually it does not follow the uterine artery, and it may be duplicated. It usually has a superficial and a deep, and sometimes it comes from the below, and the ureter may be lying in the fork between the uterine artery and the uterine vein. So we have to be careful about that. They sometimes form the ureteric tunnel, and there may be one or two small veins. So uterine vein is a very tricky thing because uterine artery stands out, and we have to be careful with the uterine vein because they are thin-walled and would retract into the structures when they bleed or form large hematomas. So joining of the external and internal iliac veins. So here the right external iliac vein is always medial to the artery at the inguinal ligament and goes behind and laterally as it ascends, because they have to join the IVC ultimately, and the IVC lies on the right side and the aorta is always on the left side. So the left always is on the medial side. So this is again another important area that the ureter crosses at the bifurcation of the sacral promontory. So that is again another landmark which we should remember. So the union of the right and the left common iliac veins. So that is again another point that usually is on the sacral promontory. And this area is also called the presacral space, and it contains the middle sacral artery, sometimes the Fallot's vein, which usually bleeds too much. So we have to be very careful, and sometimes nodes are there. So we have to be gentle in this area, and sometimes hypogastric nerve plexuses are also there. So these are some important vascular landmarks when we are doing the para-aortic node dissection. The node dissection have to go up to the left renal vein. So here the IVC is on the right side, aorta is on the left side, and the vessels, tributaries all have been clipped. So this is again, the inferior mesenteric artery is an important landmark when you are doing the para-aortic dissection. It's just above the bifurcation of the aorta, and sometimes it may get sacrificed while doing lymphadenectomy. So the anatomy of the para-aortic space, when you have to remember Titanic, because most of them, the artery and the veins stand hand in hand, like the left renal veins are the hands of the hero and the heroine. So the hypogastric nerve is another important structure which has to be identified and saved whenever we are doing the para-aortic node dissection, because if we do not save these nerves, then we will land up in bladder and rectum atony. So these are the nerves which have to be identified and saved when we are doing lymphadenectomy. So this is a diagram again to show where we put the clamps. So these are very posteriorly, you put the clamp on the uterosacral, and again on the lateral side walls in the Macartney's ligament. So whenever we need to preserve the hypogastric nerve, so here you can see the spaces when we are doing nerve preserving surgery, we put the clamp somewhere here so that the fibers to the rectum are spared. And when we are not doing nerve preserving surgery, we can put the clamp here and sever this nerve. So this is a part of the nerve sparing surgery when we preserve branches of the hypogastric nerve. So this pelvic surgeries and the ureter are our best friends. We have to make them our best friends. So these are the three places where there is a possibility that we could injure the ureter. One is at the pelvic brim, where it is crossing over and entering into the pelvis. Another is at the uterine crossing of the uterine artery, and the third is where it is entering into the bladder. So these are the three places where we have to be very careful. So we have to identify the ureter, which is most important method of preventing injuries. And so again, this is another picture, and we have to always remember that the water flows under the bridge. So bridge is the uterine artery, and so ureter goes below the ureter goes below the uterine artery. So how do you prevent these ureteric injuries, especially when it's a distorted anatomy? You identify the ureter. It is amenable to identification by sight, by peristalsis, and the cord-like feel. Vasculature always runs parallel, so do not denude the ureter. And thermal injury by energy sources is an important cause of delayed ureteric injury, which gets missed during surgery. So we have to be very careful when we are using energy sources. So I think we sometimes it takes some time out on your own to find your way back home. So whenever you are in a difficult surgery, please identify your important landmarks so that you don't lose your way in surgery. So understanding of retroperitoneal anatomy is of utmost importance. Dissection along natural bloodless planes. God has been very kind and given us bloodless planes. Dissection always parallel to important structures. Correct development of the pelvic spaces will avoid all the injury to vital structures and facilitate adequate dissection. So the surgical dictums are, if you can see through it, you can cut through it. And the eyes see what the mind knows. So we have to train our mind. So never create anatomy. God has given us good anatomy. Let us learn it and follow it. So don't get lost. So this is not the way that you put the patient on the table and ask your surgery nurse to go back, find out in the surgery.com as I'm totally lost. What should I do next? So thank you very much. So again, it's anatomy, anatomy, and anatomy before you do any kind of surgery. Thank you very much.
Thank you, Dr. Bhagyalakshmi. It was a very lucid presentation, and you took us way back again to our MBBS days and PG days of understanding surgical anatomy of pelvis. Now over to Dr. S.K. Giri, sir, who will be talking about, he'll be showing a video on surgical management of cervical cancer. And Dr. Giri sir's CV can be displayed. So,
okay. Am I audible?
Dr. Yes, sir, you are.
Am I audible?
Yes.
Hello.
You're audible, sir. You can go ahead.
So you can say good evening to everybody. So this is the case of C cervix. I am going to demonstrate the open radical hysterectomy, and before we can open it in by middle incision, by transverse incision, by penistral, by malar, anything. But for demonstration, you can have a little bit of. Now you can see the round ligament and the this is the broad ligament triangle. So which Bhagyalakshmi has just demonstrated. These are a broad ligament triangle. This is a good landmark. So just below it, we find a lot of things. Now you can cut the round ligament very lateral to the or towards pelvic, as far as possible. Then you open up, you see the ureter is now very nicely visible over here. So there are a little bit of bleeding. So we would cauterize this. Now you can see the ureter over here. It is crossing at the level of bifurcation of the common iliac into external internal iliac. Now, because I'm going to remove the ovaries, so this is the IP ligament. Otherwise, we can preserve the ovaries also. There is no need of removing ovaries in all the patients over here. So the ureter is now dissected a little bit of away from the its own attachment, so that we can now I am just creating the field that is a space. This one is the paravesical space. This is the pararectal space, and this is here lies the mechanical ligament and uterine artery. So I'm just ligating the uterine artery, and just below you can see the ureter is there. Now this is the EV space which is being cleared. There are usually four spaces on both sides. This is the fifth space, and there is a posterior space that is called rectovaginal space. So this space you can dissect it by your cautery. I like my scissor. I love my scissor to do surgery over here. And if there is a little bleeding, we can have cauterizations. Okay. So bipolar is, I know bipolar is a better cauterization in this particular area. Now the same thing is being done on. Now this is again ureter is being dissected, and now this is the uterine artery being ligated on this side. Okay. Now this is ureteric tunnel is being created on the right side. So what Bhagyalakshmi told, you should be very careful in this ureteric tunnel because there is a little bit of bleeding over here. Usually it happens. So this bladder is being dissected more on. This is called deroofing of the ureter. On the the tunnel is formed by this is the broad, this is the McIntosh ligament. So now on this side, this is on left side, this space is being created. It can be created by your finger. It is created by the sharp decisions. Now you can easily see this is the paravesical space, and now during paravesical space decision, you can see some vein over here. You can see here there is a vein. So this is paravesical. These are usually avascular space. This is this space. This one is the McIntosh ligament, and this is the uterine artery, which is the entry to the McIntosh ligament. So once now this vein is there. This vein most probably the uterine vein over here, but I cauterize this, and then ligate this, and this is the now again I'm creating the tunnel over here. So dissecting little bladder away. Hello. Now this is the I'm just going through the denervular fossa. This rectovaginal space is to be created, because we have to go a little down and take. This is the way I do the creation of rectovaginal space. Put your two fingers. This is the ureter, and this is the ureter over here. This is the uterosacral ligament, and I'm just dissecting some part of the venous. This is nerve that is inferior hypogastric plexus is over here. This is, you can see. I'm not doing this. I'm not doing here at all this nerve sparing surgery, but I'm just for demonstration sake, I'm dissecting some part of the, and I'm just cutting the uterosacral ligament over here. So this is the uterosacral ligament. And uterosacral ligament, sometimes it is called also uterorectal ligament, because it is attached to the rectum, or the Bhagiyalakshmi has already told. And the same thing on and now the same thing done on this left side also. Left side, again, you dissect. I'm planning to dissect some part of the nerves over here. You can see the nerves here. You can see the nerves. This is the, so in nerve sparing surgery, usually we try to preserve the nerves so that some the voiding problem, and there may be some sort of, you can see this is the uterosacral ligament on left side. Okay. Now after this dissected the uterosacral ligament, it becomes a single tunnel, single tube, because this is not there. This tube is then here is the, I'm taking this parametrum over here. The parametrum has to be at least, it should be 2 centimeter minimum away from the cervix, and this is on left side parametrum. You can see this is the length of parametrum I'm planning to take it. Okay. So by now we already dissected the ureter a little bit away from our dissecting field, and this is the parametrum on, again, on right side. This is paracolpus, you can say. This is again this is paracolpus on the left side. Usually before I put the peck in the vagina, so that what is. Now I'm opening the vagina over here, and you can see. So once vagina is opened, and you can see the growth and this parametrum. The growth is this is the growth of the cervix, and this is the vaginal length, and the parametrum is dissected out. And usually what I do not close vagina. Usually keep the running suture, and it has got its own importance in that it does a natural drain, gives a natural drain over here. And moreover, when there is during follow-up, and it gets really healed, and you don't have to bother if there is a vault recurrence, because vault recurrence will be easily visible and early visibility there. Now you can see both side ureter is there, but ureter, this is the external iliac artery, this is the external iliac artery, this is the rectum, and now I'm going for the lymph node dissection. Usually I go from down above, not from above down as it is done, because I feel it is very convenient for me. And this is the circumflex iliac vein, you can see here. So our limitation is up to the circumflex iliac vein, and I usually like dissecting by scissors, and sometimes also I've demonstrated also dissecting by bipolar. Now you can see easily it is coming out. This is external iliac artery, This is the external iliac vein, and this is the obliterated umbilical artery. This is the ureter, which is visible. And you can see this is genitofemoral nerve is there. And this is our lateral limitations. And you can see this is the common iliac node. This is the extent of the, this is the type 2 lymphadenectomy, you can say. Because type 1 is up to external iliac, the type 2 is up to common iliac. So this is the confluence over here. This is the external iliac artery, external iliac vein, circumflex iliac vein over here. This is the obliterated umbilical artery. This is our lower limit. And these are the posterior division. You can see this is the posterior division of the external iliac artery. This is posterior division. And you can see lot many venous plexuses will be there. And now I'm going to the deeper. This is obturator fossa. And you just dissect it. Obturator nodes will be easily visualized. And you can see what Dr. Bhagilakshmi was telling, obturator nerve, which is there. And obturator nerve sometimes is entangled in the in this node, and we may get injured. So if you get injured, there are lot many problems. There may not be any problem at all. So accordingly, we should be very careful. This is the obturator nerve. This is the obturator nerve over here. And don't go deep to the obturator nerve because it may bleed, because all the venous processes which are there in the pelvis, they are just below the, or you can deep to the obturator nerve. And here I'm doing everything by bipolar seizures, bipolar cautery, and you can see it does not bleed much because bipolar has got its own hemostatic ability. And now you can see these are all the vascular structures over here. These are the external iliac, this is the internal iliac vein, and the same thing is done on right side. I've deliberately shown it here just to show you a little bit of accident which is on faced on that same patient. And during just you see there is I was dissecting with my scissors, and you see there is a one accident occurred over here, and you see just see. So there is a venous injury over here. So venous injury, yes, it can occur because we are working in the vein and artery. There is chance of venous injury. This is a small injury which nick over here, and which can be repaired. Once you are working, you should be prepared to do this repair work yourself. So you can see there is a easily it could be repaired. Then I did I do the lymph node dissections later on, and all lymph nodes could be dissected out. And this is what I did is this is the I kept the vault open, and you can see the external iliac artery. This is obliterated umbilical artery, and this is the uterine artery which I ligated earlier, and this is the posterior divisions of the internal iliac artery. Okay, and these are all venous plexuses. This is the obturator nerve. And this is the circumflex iliac. This is the genitofemoral nerve, and so this is the external iliac artery on right side. This is the internal iliac artery. Okay, so now this is the circumflex iliac node. This is the rectum over here. So I'm almost at the end of I'm closing it, but I like to show some anomalies which we may face during this. This is the uretary anomaly. This is not the same case, but I saw one case during radical surgery. I found there are bilateral double ureter, and I searched from this side. I searched from very to bladder to the kidney, and there was bilaterality. Sometimes we find the bifid ureter, but here we found bilateral double ureter was there. So very careful. So once you were in the pelvis, we should be very much used to see what are the ureter, how it is behaving, where it is going, so that we don't repent at around. And in the pelvis also sometimes we get this ectopic kidney. So ectopic kidney, this just sit over here. This is in the pelvic kidney. So you cannot just remove it saying that it's a mass or something like that. So be careful about that. And so double ureter is a very rare finding, but yes, it can happen. It can happen. So this is how My presentation is almost over, and it was. Thank you very much. Thank you.
Thank you, Giri sir. It was really, truly wonderful and very informative video. And I'm sure the audience and the participants have really learned a lot. And over to you, Dr. Bhagyalakshmi ji, to take up from here.
Thank you, sir. Meg, madam. Yes,
Yeah.
she's here.
Yeah.
Yes, madam. So we are done for the day. I think all of the speakers have done their work excellently.
Very well. And sorry for a little bit delay because it was an inaugural day. So we had to, the timings were a little bit extended. But I think tomorrow we are going to start on time. And all the participants, please be there for all your certificates. You require the presence all 3 days. I think, okay then. Thank you. Thank you, Priya.
Madam, we still have 367 people attending. So
I can see.
Very good strength. Very good strength. About 550 people joined this first day, and it was very nice. Thank you very much.
Thank you very much.
Congratulations.
Thank you, madam. So we invite all of you to be there at 6 p.m. sharp tomorrow. There are still more exciting talks tomorrow. So I think.
You have taken the photograph of faculty. Okay,
No.
no problem.
I can take one.
Ask Raghu to take some few photographs of the faculty whenever they are there.
Okay, Mr. Raghu.
Yes,
I think
madam. Yes.
He'll be hearing. Yes.
Yes, madam. Please tell me.
Now we are 3 only. Na? That time now we are 3.
No, we have taken some pictures also.
Because now I off it.
No, I'm going to give you a recording. I'm going to give you a recording of this whole thing in a link. You can share it. The link will be provided to you.
Okay, thank you so much. And Dr. Partha Basu has left. So I think Dr. Nirja is also. Dr. Nirja is there.
I went off from my
Yes, madam.
Don't ask Raghu to promise others that we are giving the. This is ICOG, recording. We have to,
That's ICOG property. So we will decide what to do with that.
Mr. Raghu, you don't promise anybody like that. It's a college property. Don't do that.
I will just stop, end this meeting, and we can probably reconnect to this.
Okay, no problem. Thank you very much.
Because the webinar is going on. That's why.
Okay, no problem. So I think now Bhagyalakshmi, we are meeting tomorrow. Should I leave now?
Yes, madam. We think we all can leave now. So thank you very much. Thank you, Dr. Nirja, so much for coming in. Suddenly, we are requesting you to deliver a talk from nowhere. Madam, thank you so much.
Thank you so much. I wasn't sure because my laptop is giving so much trouble, but I'm happy I found something.
Nirja, I was there. Nirja, I was there in the Rio meeting.
Yes, thank you so much.
I was in that executive meeting and I saw you presenting the whole of the guidelines and a question, Dr. C.N. Purandare. I was in that hall of the FIGO managing committee. I was there.